We have Dr. Massimo with us. Welcome, Dr. Massimo,
Good.
on the board. And from Evelina Children Hospital, Dr. We have Mikhail Chua from SICK Torano. And we all know Professor Sardar Tekur from Turkey. And so
Together with Malik. Yeah.
and along with Professor Malik, of course. Yes. And so I begin with first case. It is a 3-year-old male with complaints of urinary leakage since birth, increased frequency, and weak stream since he was toilet trained. And he also had altered gait and constipation. So the history of present illness continues at the parents report that the child had continuous urinary leakage without urgency, often described as constant wetting and undergarment since early infancy. The child has never been fully continent. The parents also reported a weak urinary stream since early childhood with straining to void, prolonged void, as well as he also had post-void dribble. Parents also reported bilateral lower limb weakness, which has been non-progressive since early walking age. And parents describe the gait as the child walks awkwardly. He drags feet while he makes attempt to walk. And he also had difficulty in walking stairs. And he had many a times falls when he was unsupported. So a little bit he also had bowel symptoms with passing stools 3 to 4 per day in 3 to 4 days, and with Bristol 2/3, and he also had straining during defecation as well as frequent bloating. As far as the past history is concerned, he had 2 episodes of febrile UTI in the last 6 months, requiring hospitalization. And there is no history of, as such, dysuria or foul-smelling spleen, no history of sudden neurological deterioration, no history of acute worsening and radicular pain, no back pain. The birth history in brief is the first child in the family, full-term LSCS for prolonged second-stage labor, and there is no NICU, ICU shifting, no details of antenatal history, as well as the immunization. He was adequate for his age. And the developmental history included delayed motor milestones, especially walking, toilet training, child never achieved dryness, and he although he has a normal cognitive development. And the past medical history, he had history of catheterization during first febrile UTI for difficulty in voiding, and conservative management was given, but the child could not make any stream. Family history is there is no maternal history of diabetes or even any specific vitamin deficiency, and he had one younger sister, no congenital anomalies in sibling. On examination, weight was slightly low to age, height was 82 centimeter, BMI nearly 14.9 kg. The vitals were also within normal limits.
Is presenting like a postgrad.
Yes. And these are the examination findings. He had visible fullness in the suprapubic region, and he has a distended bladder, and otherwise bowel sounds were normal. And this is the back examination, and he has gluteal regions, flattened gluteal grooves on both the sides, and there was a reduction in the bulk of gluteal muscles, and gluteal cleft was also wide and slightly shallow. There was no midline cutaneous stigma, any sinus or tuft of hair, Skin over the lumbosacral area appears to be normal in the texture. On palpation, there was a loss of normal sacral contour. So genital examination, external genitalias were absolutely normal. Anal opening position was normal, and the perineal sensation in the region of S2, 3, and 4, it was diminished. So I just a bit it. Dr. Alok is presenting this case. Dr. Alok, are you there?
Yes, sir. Good evening, sir. Good evening, sir.
So I have given you a brief history and clinical examination. Tell us how to do neurological examination in pediatric urology OPT.
Yes, sir. Sir,
Let me introduce Dr. Alok is our third year resident at Lucknow.
good evening, respected teachers. Sir, the neurological examination that we used to do at our OPD is the mostly focused neurological examination. That includes the overall assessment of the child, including the gait, then about the sensation, the light touch, pin prick. Then we used to look upon the overall muscle bulk, then sensory examinations, the reflexes, sensations, and bulbocavernous and cremastic reflexes, sir. We usually also take the help of our neuromedicine for any detail if we require during the evaluation of the child, sir.
So I ask simple question before this question goes to the panelists. How do you examine sensation in a young baby?
Sir, usually we used cotton wisp, sir, the small cotton wisp. And then we can also use the safety pin, the blunt end of the safety pin, sir,
So,
for light touch sensation assessment, sir.
so I will go to Dr. Chua. He does lot of neurogenic bladder. I understand Massimo is also having a huge. Then I will come to Professor Tegul. Yes. Dr. Chua, please. A young
Yeah,
baby in OPD. How should a resident examine? Please.
so for a 3-year-old, particularly for this case, probably they can tell if you are touching the patient. So I would say for 3-year-olds, it's pretty straightforward. But for neonatal ended, what Dr. Alok mentioned, those are probably what we would do as well. Or sometimes you may pinch a little bit, not too hard, but they'll withdraw and you kind of have an idea that they feel it or not.
Dr. Massimo?
I
Want
think
to add?
that I would agree with what said earlier, and I think that the most important is what you just showed us, the how the muscle development look like, how the bump look like, and the cleft. Sometimes this is a missed because you focus on the frontal part, you do not have appreciation of the back, and this is a very important part not to miss. So my suggestion is that what you last slides show, that you have examined the back, you examine the spine, examine the glute. It is a very relevant part that never have to be missed.
Yes. Professor Tegul.
Yeah, everything is already been mentioned.
Okay.
The older the child is, sorry, it's easier to see if there's a neurologic abnormality or not. But the younger the child is, becomes more problematic. I rely on looking at the sphincteric tone, the anal sphincter. I find it most objective for myself. And I also look at the bulk of muscles in the limbs and to see how they've grown. But as the child is getting older, those deficiencies will become more visible, and it's going to be easier for you to judge that this is a neurogenic problem.
So, Dr. Malik, do you remember during our residencies, we were just told, just like an adult patient, putting our thick, big fingers into the anal canal, knowing the anal tone. Is that feasible, advisable in a young child?
No, I don't think so. We should be doing that. We can actually nicely put a cotton whisk and see whether there is external sphincter contraction or not. And that's it. I don't think we should really put, if at all we would like to do something, it should be a small little finger, well lubricated, and then the child should be fine. But I think we can avoid that and still do a good neurological examination.
Yeah.
So, Yes.
You can just touch the sphincter like you're pushing a button, and you can feel the tone without putting your big finger in.
Yeah,
Yes,
agree.
correct. But simply touching with the cotton swig or with gentle warm finger, we can
Yeah.
simply see is there any twitching or wincing in that area. Dr. Takwani,
Yes, sir.
would you like to add?
No, I agree with you. Yeah, perfect.
So, Dr. Prasanna is there?
What I want to tell resident that is a very important the aspect which we have discussed, and that they should regularly practice without giving excuse the child was cooperating or not cooperating.
Correct. So, examination is usually passed in most of the time. The clinical diagnosis on the basis of previous history with neurosurgical intervention, most of the time the diagnosis of neurogenic bladder is written on the files. Yes. So, I give you, Dr. Alok, the examination here.
Yes, sir.
Yes. So, these were the findings.
Okay, sir. The examination finding, the kid having decreased tone, especially in the distal lower limbs, that showing the distal wasting of the muscles. Power is decreased. Ankle reflexes is absent, and the plantar is flexor. Sensory examination, as we can see, there is decreased sensation in the posterior thigh, leg, foot, and perineal region, especially in the S2, S4 dermatomes. Gait, as in the previous history, it was also mentioned that patient have difficulty in walking. Gait is altered here, and sacral reflexes, anal wink, and vulvocavernous reflexes are reduced. Perineal sensation is reduced in S2, S4 region, and voluntary anal contraction is weak. So it overall it signifies that patient is having difficulty in bilateral lower limb, and the muscle bulk, tone, power, everything is reduced, sir.
So, Dr. Chua, will you add anything else to this list, or you are just happy with this?
That's pretty good actually. Able to look at how the gait is pretty important as well among this age group. Although there are probably 3-year-olds who have a pretty stable gait, so that's probably one of the sign when you see a patient coming to your clinic and seeing how they walk, kind of give you an idea already. And then I guess the next thing that need to be differentiated if it's a lower motor neuron or kind of mixed type of a neurogenic issues right now.
Dr. Massimo?
I nothing more to add. I think that is extensively focused and checked.
So, okay. So, Dr. Tegun?
Yeah, everything is said.
Okay. So, Dr. Takwani?
Agree, sir. Agree.
Dr. Malik? I
Yeah,
think
go ahead. I think
go.
fine.
Okay, okay.
Uh,
So, the
we,
next slide is very important.
we will jet in Ansari sometimes if we feel something to be added. So don't worry about individual of us. I think then it would discussion.
We'll jump in if we
We'll
have
jump.
anything to say.
So, Alok, what is so far? What is your differential diagnosis now? You have detailed history,
Yes, sir.
clinical
So,
examination also.
yes, sir. So the component based on the clinical findings and examination, obviously patient is having some neurological component associated with lower tract dysfunction. So the first differential would be the neurogenic bladder. The cause may be the caudal regression syndrome, as the sacral contour was absent on the examination. Still, we can keep the bladder bowel dysfunction as another differentials. And due to patient is having lower tract dysfunction, so we cannot completely exclude the anatomical outlet obstructions like posterior urethral valve or any other congenital urethral anomalies.
So, Dr. Chua, will you add anything beyond this?
This is pretty extensive actually. Yeah.
You are happy with this?
Yeah.
Okay. So,
But the answer, I mean, I think it's quite clear that do we really think that this patient may have bladder bowel dysfunction while there are so many neurological problems already visible? I don't think it's even in the list anymore.
correct,
After
correct.
having, yeah.
Yeah, absolutely. but this just to leave a list so that they have something in their mind, and
Yeah.
that can be explored further with a next set of investigations.
Okay. All right.
Yes. So, Alok, how to proceed further as far as the workup is concerned in this child now?
Yes, sir. Sir, we have already gone through the detailed history and examination. So, further, we can do the renal bladder ultrasonography for this kid, and we can look upon the serum creatinine. Then, urine analysis should be done because already patient had a history of febrile UTI that was requiring admission, sir. After reviewing these labs, we can evaluate and then we can proceed further, sir.
Ansari, I think we
Yes.
would probably add a little to what Alok said, that
Yes, please go ahead.
in the ultrasound, we should be looking for the post-void, the full bladder and the post-void residue. That is one definite thing which we should be definitely asking for in the ultrasound. And
Correct.
also, we should also look for the rectal diameters in these. That will also give us whether how long the constipation was there. So one or two of these things need to be added, and I think we should do a creatinine and without second thoughts about the whole thing. And I think the first choice we can probably add a MR to this particular child straight away without second thoughts.
So, this is in brief.
Yeah.
Happy?
We would add a VCUG once we get the ultrasounds, but till that time probably we hold on. That's the thing. Definitely, yes, VCUG, no second thoughts about that, but and the CMG too. But before that, I would really like to know the MRI so that we know what level we are actually at and what is the cord scenarios, because we know that it's S2, S3, but we still would like to know whether it's a tethered cord or a caudal regression or if there is a syrinx. All these things would matter for us on the long term. Whether he is associated hydrocephalus, the mentation would be normal, but if it is a mild hydrocephalus, it would not be. So I think an MR here is my definitely yes is an MR here before we go ahead on the renal.
Yes.
But the first will be the sonography. I agree with that. You agree, Malik? The
Yeah, that's right.
sonography?
Yes,
Yeah.
but I wanted to add the residuals in the sonography when you ask for
But with that, I would like to add also focus on the bladder wall thickness.
Oh,
That is
absolutely.
also equally
Yes.
important. So let us see what they have given in the
Well, Dr.
sonography.
Ansari, I know that this is from the guidelines, but we don't really need to do this in that serious. We would do everything, starting from the most minimal invasive, which is the ultrasound, and we look at the blood levels, and then we will have to do a VCG or a video aerodynamic study, plus an MRI.
Correct.
And I'm not sure if nuclear medicine should take place early on at that point, till we see any image visible on ultrasound or any possible image on the ultrasound.
Correct. I agreed. So, Dr. Chua, first.
So I noticed that the patient's weight is actually low, and the creatinine, by that being said, might not be accurately representing the renal function. Hence, here in Toronto, we start using cystatin C to account for a possibility of a low muscle mass and to get a better idea of the renal function.
Right. Dr. Massimo?
So my point is what Serdar mentioned. I don't think that for the element we have so far that we have much of a doubt about what we're facing, and therefore, in my opinion, I would request every test. I don't necessarily expect to be a sequence of events, because inevitably you are talking about something that will require a urodynamic, will require a bladder assessment, will require an MRI, and in my opinion, will require a nuclear medicine just to have to set the scene, just to understand where we are. Obviously, I'm not fussed about the sequence, means that any of those tests can be sooner or later, depending on availability, depending on practicality. Just a comment about the creatinine. Yes, of course, creatinine has the downside of being related to the muscle, and it might be not an ideal scenario when you have low muscles. You remember we had discussed about the evidence of the cystatin C, which can have a similar benefit and downside with the creatinine. And once this is not as a first line, but once the first line of those tests are done, particularly with regards to long-term renal function, what we do in this scenario, we will think about a measured GFR. This is just as a protocol that we follow because we trust more the GFR than the creatinine, but definitely won't take place as a first line because this is more for longer term, more to have an idea about future changes.
So cystatin in Evelina is being done regularly?
We do not do cystatin. We can do that. We do not
Yes.
normally do that just because we feel that the level of accuracy creatinine and cystatin are similar, and we trust more of a measured GFR when we are concerned about creatinine related to muscles and so.
So we had a talk about the ultrasonography also. Here is.
Ansari, I would probably agree with Dr. Massimo about the cystatin C. Enough data which says that this is really not a substitute for creatinine, but it could be a complementary thing for creatinine. But I think measuring eGFR is far more essential going ahead in assessing the overall global renal function in any of these, both in children and adults.
Okay, right. So
And one
Alok,
other
this is
point, Ansari, is that
Yeah.
actually what we're looking at the baseline renal function. What's more important is to compare what's going to happen in the future with that baseline measurement.
correct.
We don't expect a major renal insufficiency at this point, looking at this ultrasound.
Correct.
So, and this is more important to see. It's a for monitoring tool for us, more important than naming the renal function deficiency at this point.
Correct. I agree. Alok, so this is the ultrasonography. Quick pass
Yes, sir.
through just.
Yes, sir. So the images showing the bilateral kidneys and the bladder. In right kidney, we can see the pelvic calyceal system are dilated and parenchyma seems to be thinned out. So it would be SFU grade 4.
Left kidney.
Whereas in left kidney, although the pelvic calyceal system is dilated, but parenchymal thickness seems somewhat normal. So I can say it is SFU 3. Sir, for bladder, I just want to know, are these post-void images or these are the normal images, sir, during
So
filling images?
yes, this is post-void. This is post-void.
Okay, sir. So, seeing the post-void images, the bladder is obviously distended, wall appears thickened, with bilateral distal ureteric dilatation, I can see adjacent to the bladder, sir, signifying bilateral hydroureteronephrosis.
Correct. So, Dr. Tegol, how do you describe in your cases like post-void residual? Most of the radiologists, they just simply write significant. What do we understand by significant in just 3 and 4-year-old? It is 15%, 20%, 30%.
You can measure the amount of urine left in the bladder after voiding. And if it's more than 20%, I would consider significant. 20% of the expected capacity for age.
Yes.
But I think that looks significant. What's I think also important here, what I see is one ureter is dilated more than the other one, which may be an indirect sign of this one refluxing, and the other one is more obstructed. Because that's what happens when in most of the neurogenic bladders or even valve bladders, that there is reflux to one side and this is protecting the other one, acting like a pop-off mechanism. So, and the right one is more affected by the pressure I see, and the left is less.
Correct. So this is a very good observation. Yes. And Dr. Massimo, please.
Just want to add that contextualize the numbers is very important because just a number doesn't tell the whole story. So definitely, Serdar mentioned about the expected bladder capacity. Of course, so if we are in a teaching scenario, we should teach how calculate the expected bladder capacity. The rule that we use is age plus 1 times 30. That is how we calculate it in above 2-year-old children. But also it's important to understand the starting point, so the void volume, and then you then give a different thought about the residual based on the void volume. Because if the void volume was on an extremely dilated, distended bladder, has a different role than if the bladder was half empty and left half of it behind. So definitely the absolute rule, I agree, is 20% of the specter, but also be contextualizing the voided volume to understand what is voided versus what is left.
Correct. So we move on to the next slide because we had already described the sets of the tests. And this is VCUG. Alok, quick
Yes, sir.
walk through the VCUG.
Yes, sir.
And the plain film are also very important. Yes.
Yes, sir. In this VCUG, the plain and lateral films are showing the bony landmarks. As we can see, there is some abnormality in the pelvis, especially in the sacrum, either hypoplastic or partially absent. The maculating images showing the irregular outline bladder with poorly defined bladder neck opening. There is bilateral vesico-ureteric reflux. Right-sided, it is grade 4. And left-sided also there is reflux. It is mostly grade 1. In post-wide images, there's no much difference in the maculating images, the post-wide images. So mostly the patient was not able to void during the command set. That I can appreciate in this.
But
I'm
sorry,
not
the post
sure.
void, I can still see the catheter. Can I not?
Yes.
That doesn't look a post void.
Mhm. Yeah, there is a tube seen. Yes.
Yes.
And also, I'm not sure if there's reflux to the left side. It's more like a diverticular.
I agree with that as well.
Okay, so will you corroborate, Dr. Tegul, your finding on reflux on that side? You said that the ureter is also very dilated. And I will ask, what do you have in your gut? So your gut feeling showed that there may be a reflux on that side.
Well, if there is asymmetry of hydronephrosis, most often one side is reflux and the other one is not.
Yes.
In neurogenic bladders or infravesical obstruction ones. It's not a rule, but it's a gut feeling, yeah.
Yes. So the next we had also, we also talked regarding this renal scan also to know the functional status. And this is the scan done on this child. Alok, please quick.
Yes, sir. So the above images showing the photopenic defect in the superior and inferior pole of the right kidney. Otherwise, left kidney seems normal. This photopenic defect is mostly on the right side, sir.
Alok, what it represents, photopenic areas?
Sir, these are this may be suggestive of acute pyelonephritis, sir.
So
But
inflammatory change is because of pyelonephritis, which is
yes, sir.
still not converted into the scar, because in the scar
Yes,
you
sir.
will lose the contour. Here
Yes,
the
sir.
contour is still maintained, right?
So
Okay.
we have to repeat it after 3 to 4 months, sir. That would give impression of the scarring, sir, if there is loss of contour.
Correct. So next test we talked about, and this is the break of the renal function, both contributing to nearly each other. So what are coming to the next test? We talked about the MRI also. So what are the basic? It is a straight question. If it is a neurogenic bladder, then you have to have some investigation for the spine also. But are there specific objective to getting MRI in these kids?
Yes, sir. So, according to guidelines, all children with suspected neurogenic bladder must undergo spinal imaging to determine the underlying neurological abnormalities, sir. So it is considered as a gold standard for evaluating the spinal anomalies.
So what are the basic objective to get MRI done?
So we have to appreciate the associated any cord anomalies, then the presence or absence of any sacral segments, the level of conus medullaris. These things we should appreciate in the MRI, sir.
So many things which are not visible may be hidden. MRI can give you a quick review of that. So I give you now the pictures of the MRI. Yes, these are the pictures along with the report. Yes.
So as it reported that high termination of the spinal cord with absence or hypoplasia of the sacral vertebra, that is consistent with the sacral agenesis. And they also reported there is no evidence of the third cord or any intrauteral mass.
So what do you mean by this high termination of a spinal cord?
So, by reviewing the image, it seems that spinal cord termination is at the level of L1, sir. So, it is at the higher level than the usual terminations, L2, L3.
So yes, so usually it is L1 oblique L2. So if
Yes.
it is
Above that level.
yes, if there is a it is ending above that in somewhere in thoracic region, then you have high. Yes.
Yes.
So what next now?
Dr. Ansar, I'd like to comment on this
Yeah,
now.
please.
There are many MRIs are being taken for children with wetting problems or voiding dysfunction problems. Actually, MRI is not a rule for children presenting with incontinence or voiding dysfunction problems. It should be reserved for the patients as such with some visible neurogenic abnormality or findings after your neurogenic examination, or those patients without any overt neurogenic pathology but who are not responsive to regular treatment. But we do receive, I think you do the same, many patients with a normal MRI, although we would normally not do an MRI for such patients because there are no neurogenic abnormalities. So there's a bit of abuse of MRI in that sense, at least in my country.
Okay, so I beg to differ because unless we go for the MRI and evaluation, how do we know that we have some correctable neurological cause inside?
Well, I mean, if you don't, voiding dysfunction is a common problem in children, okay? So if there are no neurogenic abnormalities and they respond to regular treatment, the classical treatment, I think that's enough information for us not to need, we don't need to exclude the presence of any spinal dystrophism or any problem. But if there is any neurogenic finding, plus the patient is not responsive, then you need to exclude the presence of the anomaly. MRI is an exclusion diagnostic tool. It's not to screen the anomaly. You want to exclude the presence of the anomaly. Okay. Otherwise, you would be doing so many MRIs to many children.
So I asked this question to both Dr. Chua and Dr. Massimo. Is there a golden rule? If you are thinking in terms of neurogenic bladder, then MRI is a rule.
So I thought given the resources that would have, we might actually go with the video urodynamic first before the MRI, if that makes making the resources more reserved, because MRI needs a lot of like sometimes we even need to put them into sedation or anesthesia team. It's harder to coordinate as compared for video urodynamics. We probably will do that first and then go from there. At least we have a treatment guidance already, depending on what we see in the video urodynamics.
Correct. Dr. Massimo?
I believe that this case is quite peculiar. So you had clearly abnormality which are on the bottom, on the spine. So you really expect some MRI concern. So for this specific case, I would not have any restriction and I would just do the MRI regardless. But I agree with, again, my colleagues, it shouldn't be for everyone just because you worry. First of all, the urodynamic telling you that there is an abnormality of the bladder you can't explain, then MRI might explain that.
So you can change the sequence. So you can, after this upper tract evaluation, clinical examination, you may go for the urodynamics, need not to go for non-invasive MRI test. If needed, that can be done subsequently.
Well, MRI, I agree. MRI is not invasive, but it requires general anesthetic. So in a way, it is still invasive.
Yes. Or a small
A 3-year-old, you can't just get a 3-year-old boy stay still for 40 minutes, 45 minutes.
But not for this case. I think MRI is rightly indicated in this case.
No, this case is clear. This
Yeah.
case is clear.
But
Yeah,
there
yeah,
are many
absolutely.
patients without any visible findings or any examination findings would get an MRI. I think those
That is too
cases should
much.
not receive an MRI yet
That
until
is
So,
too
after
much.
some other
so
findings are present.
Dr. Alok, how to further evaluate this child?
Yes, sir. As teachers mentioned, we should go for urodynamic evaluation for this child, sir.
So you will not go without urodynamics, Hannah?
Sir,
It is
urodynamic.
necessary. Before prescribing anything, it is a must to go for the urodynamics in such child. It is a
Yes, sir.
palpable bladder. It was a distended bladder. In the
Yes, sir.
meantime, will you require some resuscitation in this child?
Yes, sir. In the meantime, we can catheterize the child if a patient is having features of UTI or sepsis-like features. Otherwise, we can start the patient on intermittent catheterization, sir,
Mhm.
and we can train the parents to start the kid on intermittent catheterization, starting the medication. Then we can proceed further, sir.
But since he had normal creatinine, nearly normal creatinine, but his upper tracts are dilated,
Yes,
and he has a distended bladder also, and he has a
yes.
very significant PVR also. So at least something, whether you go for, in this scenario, will you, Dr. Chua, will you go for CIC or you will put catheter drainage for a few days?
I would say better to have complete drainage first. Um, and CIC probably a bit later because we still need to teach the family to do CIC. So it's a bit of a sequence of so many workup in the moment. So probably I'll just leave an indwelling for now.
Okay, thank you so much. So I
Ansari
give
boss.
you,
Ansari boss. I think
please.
we are actually forgetting the bowel. I think we should be starting this child on some laxative at this point of time, along with what we are trying to do for the bladder.
Yes, that will be taken care, correct.
And
So
one other issue, if the patient is not presenting with urinary tract infection, I don't think that we need to put a catheter in and wait. You can directly start intermittent catheterization. And I think there is enough finding to judge what you're going to expect on a urodynamic study. We expect a high pressure bladder during both storage and also in emptying, and probably some form of a detrusor sphincter dyssynergia. So, I mean, we can start with a intermittent catheterization, then we can plan a urodynamic study sometime along the course of treatment.
correct.
And it's important for the
Dr.
child.
Ansari,
Yeah.
yeah, let him finish.
Yeah, it's important for the child to get used to catheterization because urodynamic investigation is going to be another study where catheterization will take place. And we'd like to have a more stable child at the time of urodynamic investigation. I wouldn't like to put the urodynamic catheter the first time the child is being managed.
Correct. Dr. Chua?
So for the bowel movement, our nurse usually take care of that as an instruction. Before any video urodynamics, we definitely need to make sure the bowel are clean out because otherwise the abdominal tracing won't be very accurate. So that's one of the protocol in our hospital that needs to be taken care of before we proceed with the video urodynamics. And then for the catheter, it really depends. Maybe our culture here, families are a bit resistant of doing CICs, particularly when it's 3-year-old already. You need to provide a clear evidence that they'll do it at home. Otherwise, they won't do such maneuver at home themselves. So that's the reason on our part, we need to just put in dwelling so they do nothing just to drain the bag. And then after the video dynamics, showing the evidence and at the same setting, our nurses will teach them how to do catheterization. So that's our more of our protocol or a pathway here at the kids.
So I just asked one question. This is a very commonly asked question because this child has a chronically distended bladder. After how many days or weeks of practice of CIC, this child should be subjected for urodynamics because this is an overtly distended bladder. If we do this urodynamics just after within 2-3 days after starting CIC, we may not get the correct characteristic of the bladder. So, what should be the minimum duration?
Sir, I would like to answer your question.
Yes.
I will not jump directly on the CIC. I would like to put a catheter for a few days to decompress not only the bladder, which is over distended since long, but I would like to measure the entire day or 12-hourly output, because I can judge the number of CICs, which should be a reasonable number, only after the managing the entire day output and what the patient is having the output, irrespective of what it's consuming. And then if it is consuming more, then I have to work on that also.
Correct.
And during that, it will give me liquid days also for the decompression of the bladder. So maybe in my setup, I generally do 7 to 10 days rest of the bladder before I send the patient for urodynamic. And during that time, I work for initial days to measure the output. Same time, for 2 to 3 days, I notice the intake. And then if it is horribly high, both, then I start working on that till the catheter is there, because I can convince the patient's related parents that this is now responding. And then I send for the urodynamic. And subsequently, I can judge the number of CIC as well as whether I have to consider for the nighttime drainage or not.
Okay, Dr. Chua, will you differ with Dr. Takwani?
Yeah, in fact, I may have a few concerns. Maybe we're a bit conservative here in Toronto. We would admit this patient and then put a catheter because since it's a chronic retention, there might be a risk of post-obstructive diuresis as well as a post-decompression hematuria. Maybe we just might want to monitor for a day or two, and we even refer to nephrology to help us to kind of monitor those electrolytes. Those are probably in our practice. We're just a bit more conservative in this aspect.
But this is an important observation. I recall, because in chronically obstructed 1 or 2 patients, when I was a resident, after putting catheter, he has a significant hematuria, sudden decompression of the bladder. Yes.
But that can be even there with the CIC, and then it will be
Can happen
more
anyway.
frightening. So we have to do a gradual decompression, one. And second thing, still, whatever hematuria is going to be there, once we will do any of this any method of decompressing this bladder prior to the urodynamic, we will be
Correct.
facing the same thing. We can't just avoid it.
Dr. Massimo.
I like to say that everything said makes sense, but we need to also be realistic and practical, because we say what we want. It doesn't necessarily mean it's what is happening, depending on the child and family response to it. And obviously, each circumstances, each setup, I guess that hospital by hospital, country by country, there's a different restriction, different availabilities. So you can say what is the ideal, and people will say my ideal would be A, B, C, but then you also have to be prepared to the practicality. I say CIC, but then child doesn't want it, parents not coping, then you can't do CIC. I say indwelling, but indwelling require any approach to it. Is it inpatient, outpatient? So in my opinion, you need to have some sort of a guideline. So drain the bladder. Yes, everyone agree on that. The way you will drain the bladder is by CIC or by indwelling. It has to be considered. And then checking the results of your draining the bladder. Is there polyuria? Is there any other reason? And then urodynamics, yes, we all agree, can be done because you have availability, because you have a catheter in it, or because you need to organize and maybe there are 3 weeks wait. We have to also understand that the practicality changes case by case and country by country, hospital by hospital. So I just wanted to make sure that people knows the rule. We all agree on that, and then has to be adapted to the circumstances.
I would agree with Massimo. I think the rule is that we have to drain the bladders, no matter what. And those at some point, and of course, we may change our protocol depending on the compliance of the family and many other things. One issue that I want to say, it's my personal approach also, that we like to do catheter charts a lot before we do the urodynamics, because we think that urodynamic is a very important diagnostic tool, but it's not always reproducible. And what we do, the urodynamic, is to confirm our clinical findings and explain our clinical findings. We don't use it as a primary diagnostic tool for the bladder. We observe the bladder with catheters and look at the ultrasound, look at the post-void residual. We put catheters, like we start like 6 times or 4 times a day and see how much each time is coming. We call it a catheter chart, and then in between if there is leakage or not. These are going to give us a general idea how this bladder is behaving and giving us an idea about the bladder capacity each time that the catheter is being placed. Then we would do the urodynamic study soon after this observation just to explain our findings with the urodynamic findings. Because urodynamic study, as we all know, especially at a young age, will not always reflect what's happening in the real time. It's an invasive study, and the findings that you may find in the urodynamic study may not always cope with your clinical findings. So this is our approach. We are a bit less proactive on urodynamic study. We would like to do more clinical observation before we move on to the urodynamic study.
Dr. Chua, want to say?
I agree with
Dr. Ansari, I have one more reason to put indwelling catheter in this patient. The reason is that the 0.9 creatinine with this age patient with the weight which you have described is higher, and probably having a few days of catheter will likely to give me some nadir creatinine and the chance to improve on that also. So recently I had a patient from Bangladesh of a 6-year, almost similar sort of history, and was pouring around 2 liters of urine in 24 hours. And they were doing, the father was an orthopedic surgeon, and he was doing CIC for the child every 2 hourly to avoid the leak and over-distended bladder, which is inhuman. It is almost impossible. And that's why the child was not improving as per the expectation. So most of these patients are either overhydrated or making a lot of urine. And we have to get the basic idea about that before we plan, I think, the timing of the CIC or number of the CICs.
Correct. Point is taken. Dr. Chua, you wanted to make a comment?
Oh yeah, so I was just about to go back to what Dr. Tegal was mentioning. In usual before urodynamics, indeed, we also have this protocol that we would need 2 to 3 days of voiding diary or catheter diary to have an idea about the actual bladder capacity, and so that it guide us on how much or how will be the speed of filling the bladder. Because otherwise, if we generally just use the calculated bladder capacity, may not be ideal. So that's indeed is within our protocol as well. But for this case, unfortunately, I don't know how to have a good idea of a bladder capacity assessment.
So Alok, quickly go through the urodynamics.
Yes, sir. The urodynamic in filling phase, there is at the time of command to void, there is slight increase in the bladder pressure. Whereas in voiding phase, the detrusor pressure is very less. And there is also detrusor external sphincter dyssynergia that we can note during the entire period of the voiding phase. Patient is straining, abdominal pressure is there, detrusor pressure is very less, but there is no void. Patient is not able to void, sir, even after giving the command.
So any of the panelists would like to make any comment regarding this?
I'm not sure about the numbers. What's the storage pressure like? I mean, what's the highest pressure? And there's no leak point pressure, right?
Yes.
Okay, yeah, we need those numbers. Yeah, okay. Okay, all right.
One
Right.
thing I'd
Fine.
like to
It's
add,
fine. Yeah, it's fine.
can I add one thing?
Please go ahead.
Which has to be taken in account. So we see before that this boy has a reflux. So that means that this urodynamic does not reflect bladder compliance, bladder capacity. It does reflect the system compliance and the system capacity. Just to make sure that people remember that.
It's also good if you can do it as video urodynamics and see when the reflux is starting at what pressure, and it will give you a better information about what Massimo said.
So it may be that what the filling pressure we are getting 40. Without reflux, this will be much higher. It is anticipated then?
Yeah.
Yeah. So if it is getting with bilateral, this right side, it's such a high reflux 40. So maybe in reality, the pressure may be around 45 and 50. Yes, correct.
So this is why it's important to see at what pressure the reflux is starting, especially for this patient.
Right. So what is your final now this Obviously, we could see this abdominal straightening. There is an external sphincter dyssynergia also. So coming to what, now you conclude this case as your clinical diagnosis finally.
Yes, sir. So this is a case of lower urinary tract dysfunction with neurogenic bladder, mostly due to caudal ligation syndrome with underactive detrusor. Patient is having with detrusor external sphincter dyssynergia, sir.
With hydronephrosis and
With
leading to upper tract changes.
yes, sir. With bilateral hydronephrosis and that upper tract changes. Yes, sir.
And you
And
can still
scarring.
quantify it, saying that you had a right-sided grade 4 VUR with no reflux on the left side and a significant post-void residue.
Yes.
Correct. So this is the Renshaw classification regarding this caudal regression syndrome for the other postgraduates. And what may be the other possible associations with this case, and which
Yes.
we need to, yes, look into.
Yes. The
Although you have
possible.
already described, yes.
Yes, sir. The possible association is like patient is can have gait abnormalities that needs the review and correction with neurogenic bowel and also the recurrent urine tract infections. These are
Mhm.
the possible associations.
Okay.
I'm sorry, I have a question for you. How
Yes.
important this caudal regression classification for us? Does it make a change in our clinical setting? Will it change our clinical symptoms or the clinical findings?
For the urological point of view, this may not aid anything, but for PGs, they should know.
Okay.
Yes.
I learned
I
also
agree with
about
you.
this classification. I didn't know about that.
Uh-huh.
Okay.
So how do we do risk stratification in neurogenic bladders?
So
Ask
for
AI. No, I'm not joking. So I think we are now in an era where we will get fair bit of answers with an appropriate prompt from an appropriate AI. So not ChatGPT because it does hallucinate.
Mhm.
So,
the risk stratification is that we use is based on the umpire study that has been classified into the low, intermediate, and the high risk bladder. Our patient mostly falls under the intermediate risk as the filling pressure is approximately 40 centimeter of water, and there is also potential risk for upper tract damages. So I would like to classify by patient into the intermediate risk of the risk stratification.
So what is the difference between the old classification and how much this Empire study has basically added to the newer clinical outcome?
it had to be made more simple and it helped that.
Mhm.
And one issue, I'd like to ask the question to everyone. I mean, the urodynamic study is good, it gives us an idea. But of course, the problem with urodynamic study is the reproducibility. If Massimo is doing the same patient urodynamic study at his unit, and I do it at my unit 1 week later, I may get different results. And even if you do it at the same unit at different times, you may also get different risk levels. So it gives us an idea, it serves as a basis, but it has to really reflect what's happening in our clinical observation. And it's not always fully reproducible. That's something that the young ones should also know. There is a limitation of urodynamic findings.
Correct. Dr.
Well,
Chua?
just to tag on it, please, before, if I may be bold enough, we do have as well reason that explain those changes based on how the aerodynamic is done. Aerodynamics is not an X-ray. It's not that you go there, you click a button, and you come up with an answer. The way to do aerodynamic may changes the results, as Serdar said. So there are strict rules that we normally follow. So the rate of filling, the type of filling, the amount of urine of filling, the time you expect before the empty, the way the child empty. So all those are what makes one urodynamic different from the other. And there are rules that suggest like the standard for the best urodynamic practice, which we all should be aware of and try to follow.
So in which risk group you will put Alok in this?
Sir, I would like to put my patient into the intermediate risk group, sir.
Yes, Dr. Chua, please go ahead.
Yeah, sorry. Just a quick question to the panel and everyone. When you're doing urodynamics, how many cycles do you do? And what's your rate or what's your protocol in terms of infusing the contrast with the fluid?
Yes. Yes, Dr. Dr. Malika, would you apply, because our clinical condition in Indian subcontinent are altogether different.
Correct. No, I would probably do at least 2 to 3 cycles. The first cycle, I always say, just keep it in mind, just keep it, because it takes the child a little while to relax a little, to make sure that this child is not getting overtly traumatized or something. So, but at least 2 to 3 cycles, that's a minimum thing. And my fill rates would be slow, 10 ml per minute, not more than that. And with, I would probably have the water at body temperature. I will make sure that we are not infusing cold water in these particular children.
So, Dr. Takwani,
Perfect.
do you recall our residency day? Just filling
Yeah.
bladder so many times.
Yeah.
You can't help it, because if you do one time and then you want to take it out, no, it doesn't work. The child will take some time to lot of times what we do is we put the catheters and ask the child to go around and then come back. So that's the main thing. The child is crying and then you put the catheters, then the whole abdominal pressures are bad, and they would definitely impact the bladder pressures. Let us not look at that the abdominal pressures don't impact the bladder pressures. They do impact the bladder pressures.
does,
So we
yeah.
have to be careful about those variables, which we need to take them off when you do a urodynamics. So these confounding things have to be factored in and then carefully filtered out.
So, Dr.
I
Massimo,
think there
you
are a
are
couple of things that you need to standardize, like the temperature. It should be at body temperature every time. And the filling rate should be quite standard. We don't want to go over 10% of the expected capacity or known capacity of the patient by intermittent catheterization per minute. And plus, we do sometimes more than 2, because if the first 2 do not comply or do not correlate, we would always like to go to a third one till we find at least 2 studies back to back that correlate. And one is never enough. It should be at least 2, sometimes 3 or more.
okay. Dr. Massimo, you are involved in so many live workshop through ICS, ICCS as well as ICS. So, what do you practice?
So I think that I would, again, everything depending on age and the patient that you got in front. Now, if we stick on the 3-year-old, I could probably think about 5 meals. So definitely not more than 10, as said before, even less if he's
And what will
younger.
be your choice of the tube?
Sorry?
The choice for the tubes, urethral
Tubes,
tubes.
we can use
They
6
give only
French,
one tube
6
they'll have
French,
to put.
6 French dual lumen. And then again, the rate will be 2 to 5. Toward the lesser for babies, or obviously. The total filling will be probably indicated by either the expected body capacity or by diaries that we get in advance. Again, the importance, as Serdar mentioned, to know what the bladder is to expected. And number the cycle, just you need to have a question when you do a urodynamic. And then depending on the question, if you know your answer, if you find your answer, you can have 2 to 3, depending on the situation. Obviously, I can understand that the first and the second might differ for what said before. You also have to know the limitation, and you need to be able to read your answer and to interpret your curves and your pressure. Sometimes it's just a matter of being used to, and you can yourself subtract the confounding factor. That is the importance of being experienced in the urodynamic, in performing and reading the urodynamic.
Okay. Thank you. So the participants are also requested, if they want to know some thing from the panelists. They may post their question or the queries in the chat box also. So this is the high time that you may interact, not directly, but through the text.
Yeah, the question was about the diverticula. If there's a diverticula,
Yeah.
how would you judge the pressure? Of course, we would expect that the diverticula or the reflux itself is acting like a pop-off and reducing the pressure. But it's, I mean, for you to be able to judge correctly the impact of the diverticula or the reflux, you have to do the video aerodynamics. The video aerodynamics will give you a better idea how it's impacting. But in the presence of a diverticula, we would think that the diverticula is secondary to the high pressure, and it is reducing the pressure somewhat.
But sometimes the diverticula of the bladder is larger than the native bladder.
Well, that is also another finding that you need to know before the urodynamic study. So, I mean, it's difficult to make a rule. It depends on how big the diverticula is and at what pressure it starts filling. But
Yeah, for
certainly, I
for
think
sure,
the
the
rule would
presence of
be, I mean, the presence of a diverticula is a sign of a high pressure bladder, and the presence of it will reduce the pressure, the storage pressure, certainly.
Ansari, there was another question about doing the nuclear medicine study and then put a catheter before and then to assess the appropriate function. But one should know that by doing a nuclear medicine study early, you know what is the baseline, and then you want to repeat it, maybe you can. But in this case, when you're doing a DMSA, you're not looking at greatly the issue of function, you're looking at scars, you are looking at dysplasia. If you really want to get the GFR, you need to do either a MAC3 EC or a DTPA. So when you're doing a DMSA here, it's you can do either when you initiate your CIC, or you don't need to wait for it. So that was a question which was asked, so I was just answering that question.
I agree with that.
Dr. Chua, please.
Oh yeah, so just before we proceed to the management, so with the risk stratification, unfortunately, our guideline in Canada did not apply the umpire protocol yet. The reason is they actually removed the DSD and the findings of the reflux as part of the risk stratification, which we still adapt that because we have our reason that DSD and the reflux may actually need to be considered when you're doing a risk stratification because it affects the management. So unfortunately for this case, if we're applying our own Canadian risk stratification, we still would put him on a high risk level.
So Dr. Kawan is asking, which is a better mode of drainage, periurethral catheter or suprapubic tube?
Urethral at this point of time, because it's not going to be a long term. Suprapubic, you will risk leaks, number one. And I think in children, we are not looking at putting suprapubic tubes or urethral catheters for a long term. We want appliance-free drainage, whatever way it is, whether you do periurethral CIC or you will do a Mitrofinov, whatever it is. Leave the buttons around. I don't think we are very happy with the buttons again. But the bottom line, baseline is we want a appliance-free drainage, and that's a baseline for a child. So we are not looking at suprapubic tubes at this point of time. Suprapubic, maybe yes, large bladders, lot of infection, lot of residue, and you are looking at maybe 2-3 months. So maybe that would be helpful, but not in a thick bladders.
Okay,
And if
so
you cannot put a catheter in, sometimes like you would have in the newborn valve patients, then suprapubic tube may have a role. But initially, we would always like to do a urethral drainage. If it's not doable or if it's not functioning, then you may consider doing a suprapubic.
So he has another very practical question. Usually we describe a very random number of CICs per day. Do it 3 times, do it 4 times, do it 5 times. But is there a practical number based on which we should advise families that he needs 6 times, he needs 8 times or 10 times of CIC?
We need to estimate the bladder capacity. The actual bladder capacity of the child can be estimated with ultrasound or one of your catheterizations. And we also need to estimate the expected bladder capacity of the child. Knowing that, we would be able to advise with what time this bladder appropriately look at the fluid intake. So once we modulate both of them, we would be able to give a gross baseline, whether we should do it once in 3 hours or once in 4 hours. I don't think talking about saying twice in a day, thrice in a day does help. I think it is hourly. And then we also have to look at nighttime drainages here. So these children, if you have upper tract changes like this, they do initially are benefited by putting on an overnight drainage, which would decrease the amount of fluid inside the bladder. So there is a way we need to look at how many times of CIC we should institute at that point of time.
So this is a very important question. Dr. Massimo, your thoughts. Dr. Malika said and Dr. Tegur also endorsed that functional bladder capacity or voided volume decides the number of CICs per day. Any
All,
other
all,
thought?
all of them are important. So my standard starting will be every 2 to 3 hours. That is my a priori rule. But obviously it depends how much the child drink, how much the child voids, and how big the bladder is. So depending what I'm treating, if I'm treating a bladder that I'm expecting to be small and hyper pressure, I don't want to wait 3 hours because inevitably I will have long time with high pressure and perhaps leak, so the child will not be beneficial to that. If I do have a large bladder and child has normal fluid intake and relatively normal urine output, 2 to 3 hours is my rule. Obviously, the overnight is very important if you want to consider a safer approach to the upper tract in case you do have upper tract issues.
Dr. Ansari,
Yes.
yeah, I would like to say that from my experience that any CICs more than 6 in the day is having a lot of risk carrying of the compliance. The 3-year child is not going to do by himself, and in that case, the parents, one of the family member, need to do it, and it's very difficult to do every for example 2 to 3 hours. So what I do in this kind of a patient, it's I 100% adhere with the upper tract changes, higher creatinine, and the way it is almost intermediate risk. I prefer nighttime drainage, so I will put a catheter at 10 o'clock. I will advise keep it till 7 o'clock morning and measure the output, nighttime output. It will help you in the further studying the things. And then say for these patients to start with the 3 hourly. So you can say that 7, then 10, and then 1 o'clock, then 4, and then again 7 and the 10. You put a catheter. So what at the most we can expect from the parents is not more than 6. And that is how initially I will do.
Child to go away. They
So
will
I
not.
think I do not know whether the panelists will agree with this. Besides this bladder diary, functional volume or maximum mean volume, giving an idea regarding the scheduling of CIC. It is not important to measure the 24-hour urine. That has to be divided by 5 or 6 because a child may be normoturic and another child may be polyuric. A
Yeah.
child is
So that
producing
is
2
that,
liters.
so that will get idea by the 24-hour collection, as well as the thing is that how much the bladder capacity. So the bladder capacity as per the age, or it is reduced because of some fibrosis. And second thing is the amount of urine it's producing. But any CIC which is almost 10 or 12 times is probably not acceptable, because the what you will do, who will do it 12 o'clock night, 2 o'clock night, 4 o'clock night? Because if we don't address that nighttime pressure, then eventually we are going to fail whatever CIC we do adhere in the daytime. So the our intention should be served for entire 24 hours. And in that circumstances, in to these patients to start with, I will definitely adhere with the nighttime drainage of 8 to 10 hours, and then divide the rest, as I agree with the Massimo, of every 3 hours. So
Okay.
that will give me the 6 CICs with including nighttime drainage and good decompression of the system 24 hours.
Dr. Alok, briefly summarize and just tell us the algorithm for the management of this child.
Yes, sir. So, as starting initiation with the CIC is important, then we have to understand the detrusor sphincter relationship status, the history, ultrasound, everything. Then we can quantify the patient in 4 groups based upon the video UDS finding. My patient was falling under the detrusor underactive along with sphincter over and normoactive. So for this, we can initiate the CIC as the patient is obviously having the residual urine, and continuous antibiotic prophylaxis need to be started as there is a vesico-ureteric reflux. Then further decision regarding the clinical situation based upon the findings that we have gone through, sir.
Not only the residual urine, Alok, the most important
Yes.
indication here is that you have documented detrusor sphincter dyssynergia. So allowing this child to void with that documented finding is probably is very harming,
Yes,
right?
sir.
So this patient should not void by
By
himself,
himself.
and it should
Yes.
be the emptying by the CAC only.
Yes.
So what are the these goals in this child?
Ansari, I just probably would like to jet in. How many
Okay,
of
please.
us would put this child on an anticholinergics? The bladder looks extremely bad. It is thick on
So
ultrasound.
we
It's
will
bad
come
on
to
the
that.
HCI.
Dr. Malika will come to that.
Okay,
Just I
fine.
am asking Dr. Alok, what is the basic idea or objective keeping in mind should be for this child?
Yes,
What
Perfect.
sir.
are our concerns?
Yes, sir. First thing is to protect the kidneys, sir. This is the first goal that should be kept in mind. Then further we can have to achieve continence.
Leak. Second is a leak.
Yes, sir. Achieve continence. Yes, sir. Management of the leak, sir. And third is the improving the quality of life. As the child grows, he may have some other issues that we need to tailor accordingly the based upon the patient's finding. So I would like to keep it in this sequence, protecting the kidney first, then continence, and then improving the quality of life.
Yes,
Infection. Avoid the infection.
yes.
Yes, sir.
Infection. Because he is voiding against the dysenergic sphincters also, and the DLPP is very high. So just for a quick walk through the literature. So as the proactive expectant, as you told, CIC to be executed as soon as possible, then the subsequent battery of the test can go subsequently.
Yes, sir.
Yes. So this is. So next will be the anticholinergics. Dr. Malika has already started discussion on this. So what is your preference, Dr. Tegul, regarding these anticholinergics? You start only after urodynamics or you start empirically?
We would start at some point. It depends on how the things go with the catheterization. If we feel that we need to put the catheter in too many times, even before urodynamic study, we would put the patient on oxybutynin and see how the bladder capacity is increasing. We always like to see do the management first. Then we do the urodynamics. So we would start before the urodynamics, and we would use either oxybutynin or propofurine. We're not using yet mirabegron, as we don't have the pediatric formula yet. We've been involved in the study, but we're not using it clinically yet. So those are the two things that we would use, two medications we would use. You can try any of the two. Oxybutynin is more with side effects. Propofurine is less. Yeah.
So
We're not much into intravesical therapy.
So Dr. Chua, you will agree or will differ?
So yeah, we also start using oxybutynin as a first line. However, though, our family here would read a lot and they're concerned about the cognitive development, which in adult studies they're concerned about that. Hence, we may actually start using the mirabegron as off-label already here in Toronto.
Correct.
Do
Dr.
you have
Massimo?
propofurine in States or Canada? No. You have it? Propofurine?
No, we don't have propofurine. Yeah, we only have the oxybutynin.
Theoretically, propofurine is not crossing blood-brain barrier. So if the parents are concerned about it, you can give them propofurine if it's available. Then that will make those parents more happy. I don't know if it's creating any difference, but just some theoretical advantage.
So, Evelina, Dr. Massimo, you are
So
using which one?
if we talk about a newborn with documented with neuropathic bladder, we start oxybutynin and CAC. This is not this case. This case, you have a 3-year-old, and the urodynamic did not show any DOs or any high pressure. So I'm not sure that I would start him on oxybutynin. In general, the neuropathy goes into anticholinergic plus CAC. That is as a sort of a standard blanket to everyone as a babies, because you know you are preventing this to develop.
But he has a very high end fling pressure.
I mean, it
He has
was
a he has a very high end fling pressure.
was it? I might miss that. I mean,
Yeah.
high and
So yes, it is
okay.
low he
So
did
in
not
that, I
show.
mean, I will start it definitely once the catheterization is established. Otherwise, the risk is that you do have even more difficulties of emptying.
Yes,
So
he's
catheter come first. Following the catheter is established, whatever way, then I'm happy. I will start, and we start oxybutynin. We can use mirabegron now. We have finished the trial, and we started doing it clinically now here. We don't have propiverin, which Serdar was suggesting.
yes, he has his end fling pressure of 40 centimeter.
Okay, so in that case, yes.
In
And
In
that
that case,
case,
one
okay.
one other issue is that I already told you that the only way to see if it's responding or not, it is to try the anticholinergic. I would agree that if you don't see overactivity in a urodynamic study, it's less likely to respond to anticholinergics. But you never know until you try it, because if you give anticholinergics and see the intermittent catheterization, if the bladder is pressure capacity is increasing, I think there is a use there.
Correct. So we have started clean intermittent catheterization as well as this anticholinergics. And quickly brief about the follow-up, Alok. How will you
Yes,
follow
Ansari,
this child now?
Ansari,
Yes, please.
I think I'm still realizing that we are forgetting the bowel management here.
Oh, we
Yeah.
will come. We will come. We will come. Yes, we will come. We
Okay.
will come. We will come.
Okay.
Because we, yes, first the urological management and then will you give a
Well,
nice,
it should go hand in
Hand in
hand.
hand, yeah.
Yeah,
yes,
yeah.
it should go.
Do it
Yes,
together.
yes. And this is, how do you follow this case, Alok?
yes, sir. What we usually used to perform at our institute at Pediatric Urology Center, that we used to do the first review within 2 to 4 weeks of starting the CIC and anticholinergics to check for the CIC techniques, if the parents are doing it properly or not, if any need to adjust the size and frequency. We used to assess the PVR and any UTI symptoms. If everything goes well, we can follow the patient 3 monthly for the first year, and then 6 monthly with along with the ultrasound KUB every 6 monthly, serum creatinine, urine test, MCU or VCUG if the recurrent UTI is there, or any worsening of hydronephrosis we can see on the ultrasonography.
Oh, so what are the red flag signs you would like to see?
Yes, sir. During follow-up, we have to look upon the things like if there is increasing diluted pressure or
Lot of
decreasing
background
compliance.
noise. Yeah, can you
There's
just
some
check, please?
background noise. Yeah. Okay, go ahead.
Yes,
Yes, sir.
go ahead.
So the red flag signs that we should be aware of, that during follow-up, if there is increase in the detrusor pressure or any decrease in the compliance, there is new or worsening of the hydronephrosis that we establish at the baseline. Then increasing creatinine if the patient is becoming increasing PVR despite doing the proper CIC, and any episodes of recurrent febrile UTI, persistent incontinence, or if the patient is unable to tolerate the CIC, then we have to change the management, or we can do the other therapies.
The
Also, sir.
child who is already on CIC, why do you worry about the PVR? He is not spontaneously voiding. If the
Yes,
child
sir.
is on CIC, on anticholinergic, you will monitor upper tract. For that, you will monitor creatinine. You will also see for the urinary tract infections. Will you recommend antibiotic prophylaxis along with CIC and anticholinergics in this child?
Sir, as a patient does not showing any symptoms of urinary tract infection, so just along with the CIC, there is no need of doing the antibiotic prophylaxis. But if there is symptoms of UTI, febrile UTI especially, then in such cases we can prescribe the antibiotic prophylaxis.
Dr. Tegul, he has a reflux.
Yeah.
So what?
Well, it doesn't matter. And actually, I mean, by giving antibiotics, you can only create antibiotic resistance. That's unless there are symptoms. You don't. I mean, even, you don't treat the. You don't put the patient on antibiotic prophylaxis unless there are infections. Then you would treat the patient for urinary tract infection. I want to add something. What we would do a little different than this. We rely on a lot on the chart diaries. And in the first few weeks, we would do chart diaries for sure, but then we would ask them to come every 3 months, and we ask the parents to bring the last week chart diary to us every time they come every 3 months. That will give us an idea how many times they're putting the catheter. In this way, we may just check the compliance, maybe, and also to see how the bladder capacity is changing, how the wetting or the incontinence periods are changing during the course of that treatment. It's quite an objective way of looking at the bladder behavior during the time of treatment.
And sorry, boss, one other important thing, probably Massimo and Dr. Chua would not be a privy to this issue because most of their children may be using disposable catheters every time. And for us, we will be probably asking them to reuse those catheters, and it's extremely important to tell them how actually to do the CAC and how to keep the catheter dry. So my practice would be to tell them to keep dry a catheter and then keep it in a cloth which will absorb and it will dry. And if in 3 hours, if the catheter it doesn't dry both outside and inside, they use another catheter, allow this to dry for about 6 hours. So that's extremely important. Even a small drop of water inside our catheter will cause UTI. Second thing is we should make sure that they don't wash the catheters before they put it, because water in our country is not sterile. It is potable but not sterile. So that's a big difference. We have to be sure that they should only put a little jelly and then lubrication and then put the catheter, dry catheter in, but not this. So I think these are very important points which I always see that we should emphasize to the patient. Otherwise, they'll come back with definitely a UTI in the first month.
So I don't think that was the idea of Dr. McGuire for starting CIC.
No, I'm just
It
not
was
talking
it was clean, not sterile. Dr. Massimo, Dr.
Correct.
Chua, please.
I mean, this is a very good point and very interesting for me to hear that. Obviously, you said correctly is a clean intermittent catheterization, but obviously, if you do have an unsterile environment, I mean, not just unsterile, unclean environment, if you said that you can't trust the water, you can't trust things, that's completely changed the scenario. And of course, you're right. We have the luxury here to consider catheter as a single-used instrument. So for us, that's not a big deal because we have the luxury of having single-use catheter.
Dr. Chua at Sikit?
Yeah, similarly, our government have those grant that enable our patient to purchase those single use, but they can actually put it back to the same container because there are a few products here in Toronto where the container actually would put some lube that may sterilize a little bit if you put it back after you do your first CIC. So you can reuse them, but immediately put it back to the same container. So those are the options. But it's nice to hear in India there are other way to do a clean intermittent catheterization.
So suppose Dr. Alok, on monitoring this, upper tract is not stabilizing. The grade of the hydronephrosis hydroureter remains the same. His creatinine worsens. It was 0.9. So suppose it becomes 1.
Yes, sir. That means that whatever treatment we are giving is either not sufficient or either the prescribing medications or CIC is not being properly done by the parents. So if everything is like parents are doing the CIC properly, then we can escalate the treatment. That means that these are the red flag signs, obviously. so we can proceed further with the next line of management, sir.
So no, we have tried only anticholinergic. So will you ail another anticholinergic? Will you change anticholinergic, or you will just go for add-on therapy? You will go for beta agonist to this.
Sir,
Actually,
beta 3 agonist.
before all these questions, Alok, sorry to interrupt you.
Yeah.
Yes.
Why is the child going bad? I think we need to answer that question. Why
Yes.
is the child going bad?
Mhm.
Bad is because of
He
this.
said he has inquired about the technique of CIC. The
Yes.
child and the family is compliant, but
Yes.
in spite of that, his upper tract is not dilatation
Then
is not reducing.
we need to probably redo the urodynamics to see and the MCU to see what's happening.
Mhm.
Sir,
Suppose
I would strongly suspect that the overnight drainage is very much important here. And the number of CIC should be in the range of compliance of the parents. We could not just dictate that you do every 2 overlays. That becomes around 12 CICs, right? That is almost inhuman. Though they have not painful urethra, but for the parents to perform, right? In that case, strongly, if you, I have seen this kind of a typical response of these patients with this kind of a treatment, where we exactly don't know the what is the output, what exactly the bladder capacity, what exactly the patient is consuming, and the starting the CIC with this specific number, they don't comply. They don't complain also that they are when how much really they are adherent with these 10 or 12 number of the CICs. So best thing is to put the see they tolerate these catheter overnight very well, extremely well, because it's not painful, and they also feel rest. So the bladder also feel rest, and I really strongly recommend this kind of a patient, a continuous nighttime drainage, at least till we understand the exact the pathology as well as the exact condition of the bladder, how much patient is consuming and how much is pouring in the night.
To
correct.
address the concerns raised by Anil, I already said that we need to look at the chart diaries. They are very, very important to give us an idea how it's done, if the patient is compliant. One of the major problems that we do see, some families do put the catheters in, but they don't evacuate or empty completely. You need to make sure that the evacuation is done completely until the last drop of urine is coming from the catheter. And they should be instructed on that very strictly. And also, you check for compliance and everything, but no matter what you do, if the problem is persisting, I think you need to change your treatment. There's a limit to what you can do with the family compliance. If they're not compliant, they're not compliant, and then you have to change your treatment accordingly.
Yes. But with that, we interviewed the family. We saw the child is doing CIC in the clinic. But in spite of that, the creatinine is still 1 and the upper tract dilatation has still persisted in spite of 6 months of anticholinergic, in spite of adding 1 beta agonist. So what next? Because we do not know about the compliance at home. So what next can be suggested to this family then?
So we can suggest second line management. We can advise for the this botulinum toxin injection. We can review the urodynamic study to look upon what is there any worsening things that we are missing about the patient.
Urodynamics obviously was done before taking for a next step of invasive therapy. This end plink pressure is still in the range of 30 to 35.
I think it's important to know if there's overactivity or not before we start botulinum toxin. Because
Yes.
sometimes they are low compliant bladders, like thick wall bladders, stiff bladders. It's no more overactivity, but more fibrotic wall bladders. And Botox will not be very helpful for those patients. So we would consider surgical treatment then maybe. And Botox would just delay our treatment and may actually be a cause of further upper tract damage before we do the proper treatment.
Correct. Because there was a trial on the application of Botox in cases of lower intake dysfunction. It was seen those kids who are having primarily detrusor overactivity abnormality, their response better as compared those who are having pure compliant disorder. This is what Tegul is saying. And in this kid, if you remember, he did not have any detrusor overactivity to begin with. He only
Yes.
had, yes, compliance disorder, high end fling pressure. along with
Yes.
DEST.
So that's but the indication still is there that neurogenic bladder that is refractory to anticholinergics for a period of 6 months. But this botulinum toxin works better with patient with obvious muscle overactivities.
Mhm. So if I give you a hypothetical situation that there's no detrusor overactivity, only compliance disorder, and the end filling pressure is 35 still. Earlier it was 40.
नहीं हमारा वो pediatric
Sir, we can still proceed with this intraretrosal botulinum toxin injection, sir, for this patient.
Dr. Teggul, he's saying there is no detrusor overactivity, but end filling pressure is still 35. He would like to give botulinum. Will you agree?
I mean, I cannot disagree the use of Botox and see what the result is. But in the short term, don't wait another 6 months to see if the Botox is working or not. If it's not working early on after you do the injection, do go to another treatment of increasing the bladder capacity. And we know that the Botox response is best in those overactive bladders, not the hypocompliant ones. But there's, of course, some inclusion of bladder overactivity, even if the bladder looks non-compliant. You may have some benefit by using the Botox, but we know that in such bladder, it will not be great. So we should not waste time to see the result of Botox and see if the Botox is functioning early on. If not, we move to the other treatment.
Massimo, you do a lot of Botox.
We
Do
do
you agree?
Botox, yes. Yes, we do Botox. Our line goes if the medical treatment is not enough. Obviously, Myra might change a little bit this scenario because it seems to be more effective than the traditional anticholinergic. But the next step in our ladder is the Botox, and then following me either failed Botox or other consideration, we go for the augmentation.
Dr. Chua, will you differ? Or you just after 6 months of urotherapy, pharmacotherapy, changing all combinations, if you're not happy, will you go for Botox?
We are having very low threshold of giving Botox here. It's almost like we are very dedicated with giving Botox. The only thing we may have a different dosing is we give 10 international unit per kilogram with a maximum dose of 300. And that's our protocol here at the kids.
Correct. So I ask another question. Will you give in the detrusor, but he's also having detrusor external dyssynergia. Will you put the Botox in the sphincter also?
No, we don't.
Yes, we do that as well here.
Dr. Massimo,
I mean, this is a external sphincter problem, not an internal sphincter. So why
but
you
he
need Botox the bladder neck?
is having significant sphincter activity also.
I
We
haven't
give
seen
external
that.
sphincter actually here.
You give an sphincter,
External sphincter.
External, yeah.
external
Oh,
sphincter.
you give Botox to the external sphincter, do you?
Yes. We're actually about to present our data next month in the
How do you
international.
inject that?
So we only give 100 international unit, but we only dilute in 2 cc or sometimes 1 cc, and you give 4 quadrants. And our report here, although the one that we're reporting a majority are functional one, we have over 2/3 of response and only 1 out of 27 patients that have incontinence after.
So just to my understanding, because of course this is new to me. So you inject extra-urethral, so peri-urethral.
We use cystoscopy and we use the Botox needle to identify where the sphincters are, and we inject 4 quadrants.
And then
Either
you
1
go,
cc
you
or
inject
0.5.
from inside the urethra to the muscle outside. And you
Yeah.
inject the 4 quadrants.
Yes.
And
So
do
there
you
is
do combine with the intra-bladder or you do separate?
We do the detrusor. There are many cases that we do both detrusor and the sphincter if we think there's a DSDs. Yeah, and with the overactivities or the procedural.
yes.
There are some reports on the use of Botox on the sphincter, but none of them are well-structured prospective trials, and most of them are empiric treatments. And I would not disagree with doing the external sphincter injection, but that's not a definitive solution for the child. I mean, it's just going to create some result, maybe some better voiding or lower the leak point pressure and create the protect the upper tracts from high pressure. But this is not going to be a definitive treatment. So I think the definitive treatment for this child, if it's not responding to cholinergics and it's not responding to Botox, would be augmentation and intermittent catheterization.
So there is a question from Dr. Ashutosh to the panelists. Practically, what percentage of patients do they improve after CIC and pharmacotherapy? And after how many years should we wait before going for intervention or surgical intervention?
There are no hard and fast rules, Ansari. The first thing is how many years it would work. You have to follow the child very diligently. We have, as a pediatric urologist, we should realize that we are responsible for them for their life. So it is the follow-up which will tell us when to change, when not to change. There are no rules, there are only guidelines which will tell us how to proceed when there is a change, but you have to identify the change. And that is where you would do it. You postpone the augment as much as possible because that's an irreversible procedure. But when it is inevitable, it's not going to be that you are going to wait for so many years or not many years. But I think you have to follow up the child and then pick up the red flags and then act accordingly. There are no specific timelines in this particular children.
Dr. Ansari, can I add? Hello.
Please go ahead.
My thought about the augmentation in these 3 years of age patient is quite means I will consider least that treatment. Even if I'm forced to do, then I may think about the diversion, or I may think about doing the only myotomy rather than the full-fledged intestinal augmentation. So that I will try to avoid as much as, and I know there are high chances of further requirement of augmentation, but still I can delay as much as, because having a ileocystoplasty at this particular age is quite detrimental. He is having a reflux, so even the temporary, if I need divert, I can do a loop ureterostomy on that side, and that can give me some relief from this intractable issue.
Anil, when is a good time to do ileal cystoplasty? At what age?
Generally, see what Malik has said. It's completely right.
Dr. Anupam Shukla ko allow kar dena. Dr. Anupam Shukla honge.
So what Malik has said is right. That there is no outright means or tight rules, but our priority is protecting the upper tract and improving the quality of life by treating the leak. But the augmentation, I generally try to avoid till the age of 9 to 10 years of age, because by that time they're likely to manage better, because it involves the bladder wash, taking care of the emptying, proper emptying, then the electrolytes, and then the so many other issues, right, which comes in early part. Later part is we'll discuss sometime, some other part of the discussion. But that's the reason that I would like to delay the ileocystoplasty.
But if the family is doing the intermittent catheterization well, the family is compliant, and everything is in good order, except that it's not responding to treatment, I think you can do augmentation early on at this age. Of course, the later is the better, but if you're obliged to do it, there's no point in waiting or doing some other treatment, in my understanding.
Sir, is there any role of repeat Botox? Means if one session got failed, so is there any role of repeat Botox injection, intradetrusor Botox?
Anupam,
yes,
if your first session does not work, your subsequent sessions may not work because you are looking at a bladder which is non-compliant. Non-compliant basically is you don't have detrusor, you have more collagen. If the first episode does work, then I think your Botox comes into play, the second dose, the third dose, till about 10, 12 doses, so that you can delay your augmentation. But, and maybe if you can avoid an augment, that's fine. But if the first dose doesn't work, then you're probably not doing a second dose.
So at what time frame we will say that the successful Botox? Means what is the follow-up after Botox?
At
How to
the-
follow? Means how to say
uh,
that? Yes.
3 months. If at 3 months you don't find a change in the bladder dynamics, I think the Botox has not worked. That's
So
a
Now
max.
means
That's
coming
a
to the
max.
augmentation,
That's the
this side,
max.
this type of
Even earlier.
patient, Dr. Tegul, I don't want to like to give the message. Now, if my treatment is not responding, then I will again review the entire thing. That where I probably first I will check that whether I'm doing any mistake in calculating the bladder capacity, in calculating the output, in calculating the consumption, and the timings, and the number, the nighttime drainage, the compliance, each and everything I will go stringently very well. And still I find that everything is perfectly done, which is less likely because I have not seen much in this practice, that all these things, if we observe properly, right, then we fail and we compelled to do augmentation at this particular age. Because my message is very clear to the junior consultants or residents who are participating, that our threshold for the augmenting this at this age should be the minimum.
Correct. So coming to the bowel management, I fully agree with Dr. Mallikarjun. This has to go parallel along with this, the urological management. Since we had discussed first the part of part one, that is the urological management. Now, Dr. Alok, quickly, briefly tell us about how to, at least from urological perspective, we may not be as good as gastroenterologists, but to some extent we may help families and guide to take away this abdominal problem.
Yes, yes, sir. So we used to follow a dedicated bowel program, sir, at our institute that comprises certain sections. So initially, we used to consult the parents of the patient regarding the what is the regular bowel time, what should be the fruits that patients should follow, gentle massaging the child's belly, and warm bath in the tub. This helps in evacuating the bladder. If this conservative management does not help much, then we can further proceed to the laxatives, glycerin suppositories, and then further we can also proceed to the enemas.
But fluid and dietary management basically.
Yes, sir.
So you have to
It's a
inquire.
cornerstone.
Many children, they are not adequately hydrated. That may be one of the common cause of this. And a simple rule may be either give those who are remaining, most of the children remaining indoor these days, so 30 ml per kg body weight. Those who are having little hot environment, they may have even 40 to 50 ml per kg body weight. A simple calculation can be done. So, and this is the small, because dietary management is extremely difficult. And I will ask Dr. Tegul, Dr. Massimo, and Dr. Chua, how do they prescribe diet? Because younger children, they are very smart and choosy about their diets.
Well, everyone has a different way of explaining what the bowel management would be, but they're all similar. I mean, I don't think we have a miracle way of dealing with this. We do the same like many others do. And it's not easy, but we rely on a lot on enemas if it's not responding well. We teach the parents to do like enema 2 times a week or so, depending on the severity.
Ansari, I can actually jut in and then make this thing much more complex. It sense that actually we can do a nuclear study to see the bowel transit. Now this could be either a slow transit or a normal transit, or so if it is a slow transit, we need to know whether the whole transit is delayed right from the right colon to the left colon. And if the delay is only in the left colon, then your enemas and all would work a little. But if it is right, the whole neurogenic scenario is causing the whole colon to be significantly less expulsive, then you need to look at antegrade enemas in these particular children. So, in a sense, so but primarily then you need to go in for laxatives straight away, polyethylene glycol. Make sure that you expel. The first thing is always expel the whole amount of fecal matter which is there, and then look at a maintenance. So there is a methodology as the way we go about in our bladder. There is a methodology for bowel too.
Yeah, but he is a surgeon, not a gastroenterologist.
Oh yeah, but
don't make life difficult for us.
I agree.
What
So,
what I was saying that here I saw in when you mentioned the laxative, you do have mentioned lactulose only. So we do have.
No, polyethylene glycol.
Yeah.
The
there is
second
a
second line is
No,
lactulose.
it wasn't in that
yes.
Acha,
program.
in this, okay.
So we do use the macrogol, movicol,
Yes,
whatever, yeah, as well. And then sometimes you combine laxative with like Senacort and macrogol, something like that. That
yes,
is in our protocol comes before the enema. So of course enema is just quite an invasive and advanced type of treatment.
correct. Fully agree on that.
So last comment on when do we consider, because this is a morbid decision, going for surgical options. What should be the parameters when that guides the clinician that this is the end of everything. Now we should go for surgical option.
The red
The
flags have already been mentioned. Yeah.
Yeah, I think that we mentioned that already. Not responsive to medical treatment, we then will suggest surgical option is needed.
So quickly,
I would just probably add one line here that if we are going in for augmentation, make sure that you also look whether you would like to add a mace along with that or not. So that is a decision which we need to take because we don't want two surgical options going on one after the another. That is the only thing I would like to put in, but I'm not saying that every augment will need a mace. But I want all of us to make sure that we don't miss a chance to do a mace and then come back later. That's the only thing.
Dr. Chua, how commonly you do this mace?
Actually, I was about to add on to the comment is don't forget the mitrophanol already if you're doing the augment since the appendix is
Oh
there.
yeah,
Yeah,
definitely
of
yes.
course.
Then
Definitely
split,
yes.
yeah, we split it into mace and mitrophanol, and we reported quite a good number of those. If the appendix is long enough, if not, we have a Gen Surg and Gen Peds urology colleague here. His name is Rodrigo Romão, who would also start using mini ACE, which is really well accepted by the family. So we do both at the same time.
So
We do
quickly,
both at the
Alok,
same
just
time as
how
well.
to go for the follow-up, because yes.
Yes, sir. So follow-up, we have already been discussed mostly in that flow chart. Initially at 2 to 4 weeks after starting the CIC, then every 3 monthly for the first year, then 6 monthly. Ultrasonography should be performed every 6 monthly, and we can just look upon the parameters, the hydronephrosis, blood wall thickness, post-void residue, serum creatinine. If the patient is symptomatic having the UTIs, then urine test should be performed, sir.
Correct. So anything else panelists would like to follow up, because it may be different from country to country as well as patient to patient also.
My only comment would be about the enemas. With the use of peristine enemas, I think we've stopped doing the maces. I think with the peristine, we can get good evacuation of the whole left colon and maybe
Yes, left
some
colon.
transverse colon as well, maybe a little bit of it. This is the idea of the peristine enema is that you leave the fluid inside for a while and then the evacuation is much better. This is that certainly serves better evacuation compared to the regular enemas that we did in the past.
Okay. So I think we conclude this case. Basically, the basic idea for this case, just we have a thread-bearing discussion how to approach a child with neurogenic bladder, and rest other cases maybe just like a ward round quickly. Short history, diagnosis, and approach, because they will be
Ansari
having.
boss,
Yes.
Ansari boss, we may have to call it a day. A lot of it was about 2 hours now.
Okay.
So think about it because there's
Yes,
some.
I asked. I
We have
asked
been
whether.
we being called up at Ahmedabad into the conference
Okay.
scenarios. So I think we have done a fair bit of detailed thing on the because we looked at sphincter dyskinesias, we've looked at hyperreflexic augments. I think we have gone a fair bit.
It was a very good review of the neurogenic bladder in every aspect. Thank you for the case.
So, okay. So if both of you are busy, then we may continue with Massimo and Chua. One
Absolutely.
more case.
Yeah.
No issues at all.
Yes.
Well,
If you allow us,
if you can keep it short, we can stay another
Yes, the
15
next
minutes.
case is interesting, and we will keep it short. Then, then you can join the dinner after that.
Okay.
it's not the dinner mostly, but it's the campaign
we-
going on, boss.
Oh yes, I understand.
You go,
Yes,
you
I
go.
No,
understand.
we already leave that.
Anupam, quickly.
I'll bring one to
So
you.
next case will be presented for Dr. Anupam, and it will be
I can leave it.
yes.
Yeah, I'll bring it to you.
And the resident participating is Dr. Gajendra.
Gajendra, yes.
Yes.
Hello, Dr. Gajendra, are you there?
Yes, sir. Good evening, sir.
Yes, yeah. Good evening, sirs. So our next case is
Yeah,
7-year.
I'll come the fourth floor. Yeah.
Yeah, next case is 7-year male, full-term normal vaginal delivery with normal mystole. He was referred to the urology clinic from the pediatric endocrinology department with the already diagnosed case of Wolfram syndrome. So the chief complaints was increased frequency of micturition, which was about 14 to 16 times per day with urgency and nocturia since 1 year, urinary incontinence both day and night time, weak urinary stream and intermittency. There was no history of constipation or dysuria or foul smelling urine. That was the history of UTI, and there was no history of any hearing loss. So antenatal and perinatal history was not significant. The child was diagnosed with a type 1 diabetes mellitus at the age of 6 years, and he is on insulin since 1 year. The child also presented with the diminished loss of vision, diminished vision. So he was evaluated and diagnosed as a case of bilateral optic neuropathy. Among family history, it was significant. His elder brother was also diagnosed with the same syndrome, and there was a homozygous allele was present for WFS1 gene, that is for Wolfram syndrome. So on general physical examination, the vitals were stable. Height was 126, weight was 23, and BMI was 14.5, which was quite low. On per abdomen and genital examination, per abdomen was soft, back and spine was normal. The focused neurological examination was also normal. The bilateral knee and ankle jerk were present, and the plantar was bilateral extensor. So Gajen, how to evaluate this child further quickly?
So, 7-year-old male child with a known case of Wolfram syndrome. Patient is having diabetes mellitus along with optic atrophy and symptoms of frequency, urgency, and incontinence since last 1 year. I would like to first rule out any underlying infection. I will go for urine routine microscopy and culture. I would also like to order the renal function test of this child and also the blood sugar level in the recent years.
And what next, apart from the basic routine blood and
After doing
urine?
this, I will go for the uroflowmetry and PVR estimation of this patient, sir.
So urine routine microscopy and culture were normal. Serum creatinine was 0.5 milligram per DL, and HbA1c was 6.4. The patient is on insulin, so there was a very good glycemic control. So this is the uroflowmetry PVR, Gajendra. Can you read it? Yes.
Yes, uroflowmetry PVR is showing the in the first uroflowmetry PVR it is showing the voided volume of 278 ml with a maximum flow rate of 9 ml per second and average flow rate of 3 ml per second with a PVR of 30 ml, which is significant for this child. And we also this is the second uroflow PVR to introduce the reproducibility and the accuracy of the uroflowmetry. We order this second PVR, which is suggestive of voided volume of 240 ml with a maximum flow rate of 9 ml per second, average flow rate of 4 ml per second, and a PVR of 60 ml. So with a high PVR, I would like to order ultrasound of this child, sir.
Yeah, but before ultrasound, we'll see the bladder diary because the patient is having
and
storage
bladder
symptoms,
diary.
overactive symptoms. Yeah. So bladder diary shows that the frequency goes up to around 18 to 20 times a day. Nocturia 2 to 3 episode per night, along with the urgency and incontinence. Average voided volume was 150 ml and maximum voided volume was approximately 250 ml. The total output was 1.1 liter and nocturnal output was 200 ml. So what does it signify? The nocturnal output 200 ml.
Age,
Yeah.
As this child is known case of Wolfram syndrome, which consists of diabetes mellitus, diabetes insipidus, deafness, and optic atrophy. So we have to rule out the nocturnal polyuria to rule out diabetes insipidus from the overactive symptoms, sir.
So when will you say polyuria in a child, Gajendra?
When it is more, urine output is more than 2 ml per kg per hour.
It's around 4 ml per kg per hour. Okay. So what is your probable diagnosis at this point of time?
7-year-old child with a known case of Wolfram syndrome with frequency, urgency, and incontinence. My probable diagnosis will be, sir, overactive bladder in a known case of Wolfram syndrome, sir.
So as we already ruled out diabetes insipidus, which may also, which may also cause the overactive symptoms. So it may be a case of isolated overactive bladder along with the Wolfram syndrome, which is already diagnosed. So what is the next workup will you order?
Next, I will go for imaging modalities for ultrasound KUB, sir, to rule out upper tract changes.
So ultrasound, this is the ultrasound. There is a bilateral mild hydroureteronephrosis SFU grade 1. Bladder is distended with the trabeculated wall and the prominent bilateral retrovesical ureter. And PVR is 90 ml.
Sir, I would like to know the spinal involvement or the MRI of this patient. This, as we are suspecting the neurogenic bladder, and it is previously discussed in the case that MRI is also important role, as this is having cortical neurogenic type bladder, sir. So I will go for MRI, spine and brain also, sir.
Yes, so in view of high suspicion of neurogenic bladder, we should order the MRI, obviously. So this patient got MRI brain and spine as a, because to evaluate the Wolfram syndrome also, spectrum of Wolfram syndrome. So it was showing that there was a bilateral optic nerve atrophy that marked by the red arrow, and there was a brainstem atrophy. Otherwise, this scan of MRI, the spine is absolutely normal, grossly normal. So what is next, Gajin?
Sir, in view of high suspicion of neurogenic bladder, I would like to go for UDS, urodynamic study for this child, sir.
Okay. So as already discussed that in
Anupam,
yes.
I have a issue with this
Yes.
little bit because I will either do first MCU if I am not having a video aerodynamic, but if I have video aerodynamic, I will answer that my preference will be the video aerodynamic.
Yes, sir. But we don't have a video urodynamic actually. We have a simple urodynamic study. So this is the urodynamic study, sir.
So this is the urodynamic
But
study.
without having a previous MCU, do you agree with the MCU should not be done first before we order the urodynamic in these kind of cases?
Yeah, I think there should we have done video urodynamic. I totally agree, sir. Yes, because there is a bilateral hydroureteronephrosis is also there. So there may be the component of VUR definitely. So we should have gone with the video urodynamic. Totally agree, sir. Yeah.
We would like to ask Dr. Tekgul, it is mandatory to go for VCUG in all cases?
Well,
When
if there's if there is bilateral dilatation, mild dilatation, you cannot really exclude the presence of reflux.
Correct.
So at some point you need to know whether there is reflux or not. The best is of course the video, but you can do at similar time, at the same time, or the day after, or the day earlier. It doesn't matter. But you need to know whether there is reflux or not in this patient.
Correct.
So this is the urodynamic study of this child, which shows the severe detrusor overactivity, and child was leaking at every 18 to 20 ml of filling. So we cannot comment actually totally means accurately on the compliance and the end filling pressure. So what is the comment, Gajendra?
So
What will you comment based on this CMG findings?
So this patient, sir, having sir severe detrusor overactivity leak, sir, at the volume of the 18 to 20 ml, sir.
Okay, so just for a brief clinical spectrum of Wolfram syndrome, as this is a upper motor neuron type of neurogenic bladder, so level of lesion is suprapontine or brainstem. So the early bladder pattern shows that detrusor overactivity and sphincter is usually synergistic. However, it may develop into the detrusor underactivity or acontractile bladder with the poor compliance later on. So what will be the final diagnosis after getting these all investigation, MRI, urodynamic study? What will be the final diagnosis? Yes.
So 7-year-old boy with known case of Wolfram syndrome with symptom of overactive bladder and UDS suggestive of severe DO with leak. My final diagnosis will be the high risk cortical neurogenic bladder with severe DO with leak with upper tract changes, sir.
Yeah, so this is a clinical spectrum of Wolfram syndrome with high risk neurogenic bladder with severe DO and leak. So Before going to the management part, how will you risk stratify this patient, this particular child?
So in the Empire study, though the DO with severe DO with leak is not an exclusive criteria for inclusion, but though our patient start leaking at 20 ml, sir, so we can use AUA guideline to stratify this patient, sir, as the patient is having severe DO with leak and patient is having also upper tract changes, sir. So this patient comes under high risk stratification according to the AUA guideline.
Yes, so in view of severe DO and bilateral upper tract deterioration, upper tract hydronephrosis, hydroureter nephrosis, we put this patient in the high risk, because this slide shows that this is the adult neurogenic bladder guideline from where we have taken the reference, because we could not comment on the DLPP in this CMG, so we have kept this child in the high risk category. Okay, so how will you manage this child?
So this patient have late presentation at the age of 7 years, sir, and the UDS study suggestive of detuger or activity with normal detuger or activity with high PVR and upper tract changes, sir. I will start. This is a high risk of neurogenic bladder, so we will go for proactive management rather than expecting.
Yeah, before going to management, what are the goals of management, Gajen?
The goal
In
of
this
my
child, yeah.
the goal of management in this case is to control the overactive bladder symptoms like frequency, urgency, and urinary leak. The child should be dry and socially have acceptable continence and should avoid the upper tract changes, sir.
Okay. So the basic goal of management in this child is to control overactive bladder symptom, to achieve acceptable continence, and to preserve the upper tract renal function. Okay. So based on the EAU guideline, as already discussed, in the patient with the detrusor overactive and synergistic sphincter, we should start with the antimuscarinic medication along with the CIC if the PVR is high, and continuous antibiotic prophylaxis if VOR is present. So in case of clinical failure or upper tract deterioration, we should move ahead with the second line therapy and later on the augmentation. So we have started with the urotherapy along with the pharmacotherapy and CIC. We have started with the tolterodine 2 milligram HSOD, and we have assessed the response after 8 to 12 weeks. And there was a less than 50% reduction in the symptom, which was according to the ICCS guideline, we should be commented as a no response. So we have added add-on therapy with the beta 3 agonist in the form of mirabegron 25 milligram OD. So after adding the mirabegron, we have assessed against the symptom score after 6 to 8 weeks, and we found that there was a modest improvement in the symptom score. So we have followed with the again this is the post-treatment uroflowpimetry PVR after the adding the mirabegron, and it we can see the widened volume is 243 ml, but the flow rate is still low peak and PVR is still high. We also did the ultrasound KUB to look for the objective response of the therapy, in which we can see there is a deterioration in the hydronephrotic grade of the bilateral upper tract. So in the previous scan, there was a minimal hydronephrosis SFU grade 1 bilateral kidney, but in this scan we can see there is a bilateral moderate SD and SFU grade 3 with the very prominent retrovesical bilateral ureter. So what will be the next line of management? Because we will consider it as a failure of therapy, and these are the red flag sign as already discussed in the previous case. There is a deterioration at the upper urinary tract. Okay. So what will you do next, Gajen?
Sir, though as the patient is having failure on the first line treatment since last 6 months, sir, first we have given tolterodine for the 12 weeks, then we assess according to the ICCS criteria. We have given add-on therapy of beta 3 agonist mirabegron, and we assess patient on the basis of bladder diary according to the ICCS criteria, and it was the partial response, sir. And then in terms of in view of increasing upper tract changes, sir, the hydronephrosis is also increasing bilaterally. Previously it was mild and now it is moderate SFU grade 3 with high PVR. I would like to go for, sir, second line management in this patient, sir.
Okay, what second line management?
Intradetuger Botox, I will go, sir.
So how much Botox will you give in this patient?
It
If
is
you are planning for
previously
intradetuger
discussed, it is
Botox.
10 unit per kg, sir, according to the weight criteria. And at the time of surgery, the weight of baby was 20 kg. So we give 200 international unit intradetuger Botox, sir.
Okay, so we did given the intradetuger Botox 200 international unit. And on the, if you see the cystoscopic finding, urethra was normal, bilateral you was seen, and there was a grade 2 trabeculation with the chronic cystatic changes in the bladder. Okay, so how will you follow again, as already discussed in the previous case scenario also, how to evaluate the response assessment after the second line therapy, Botox?
Yes, sir. I will assess patient on the basis of bladder diary uroflowmetry, sir, after 4 to 6 weeks, sir, and ultrasound at the age of after the 3 month of Botox, sir.
Yes, so we to look for
Can I
the
stop
response.
you over here?
Yes, yes.
Have you forgotten the CIC or you still continue with the CIC
No, sir.
We will continue.
after the Botox?
We will continue with the
We have
CIC.
continued with the CIC, sir. So this is the bladder diary. After this was intratracheal Botox, we saw significant reduction in the frequency, daytime frequency, which was earlier 18 to 20 times. Now it is 8 to 10 times. Nocturia 1 to 2 times. Dysuria is still present, but there is no urgency or no incontinence. Average voided volume is 190 and maximum voided volume is 290 ml. Again, the total output is 1.5 liter and nocturnal output is 150 ml. That is, there is no element of nocturnal polyuria. And this is the uroflowmetry PVR, in which we can see the improvement in the flow rate along with the significant reduction in the post-void residue. This is the follow-up scan at the 3-month post-intraretular Botox, which shows the bilateral minimal hydrouretonephrosis and the ureter, the post, this one, the retrovesical ureter is also not that much prominent. It is fairly visible in this scan. So this is the follow-up at 3 months following the intraretular Botox. So what will you do next, Gajen? How to follow further this patient?
Sir, as the patient is having symptomatic relief on the basis of bladder diary uroflowmetry PVR and ultrasound, sir, we can repeat UDS scan at the 6 months, sir, or we can wait for 3 to 9 months at the effective period of the Botox post injection, sir. Or if patient
So,
develop increased frequency or patient becomes symptomatic.
so I will ask to the panelists, sir, is there any role of video, means urodynamic study if the patient is significantly improved in the symptom, ultrasound shows that reduction in the hydronephrotic grade, and the uroflowmetry also shows the reduction in the significant volume of the PVR. So do we need to go for
So
the CLG?
knowing the entire story, I would
Sir, your
not
voice is breaking, I
attempt
think.
UDM at this juncture. If the patient is doing well, I believe the Botox is working.
So what will
The
be the further
Botox
follow-up? Yes,
is
what will be the
working, and then I will continue with the Botox every 6 to 9 months.
May I make a comment?
Yes, sir. Definitely.
Okay, I am older than many of you. Maybe you looked at the publications in the past. When we first published on Wolfram syndrome, I think it was one of the largest series in history in the literature. It was about around 2000. And what our conclusion was, despite the fact that it's been reported, Wolfram syndrome usually manifests itself with large atonic bladders. It was the first time that we mentioned that some of them presents with overactivity. And actually, you have shown that slide. This is a progressive disease.
Yes,
It starts with overactivity, dyssynergia, but in the long run, they all turn into large atonic bladders. And I'm not sure if it's the effect of Botox or it's the natural course of this problem. Those bladders will grow in size, the capacity will increase, the emptying will get worsened, the upper tract changes will not necessarily go any better because polyurias will become more important. And those children will not live long because most of the time, for other factors involved, their lifespan is much, much shorter compared to all the others. And it's good to follow the neurogenic bladder guidelines. However, this is not a real neurogenic bladder that we are accustomed to do, like the spinal dystrophism. There is a central component to it. The pons is also involved. So this is a bit different than the others. And most of them, in time, will get, the bladder will, as you've shown it very clearly on the ultrasound, the bladder wall thickness has gone down significantly. I don't think it's the effect of the Botox. It's more the natural course of the pathology. And all you have to do, you keep on doing the intermittent catheterization and everything, and there's not much else to do for this child, and he will have other problems. The diabetes mellitus will get worse, and it will have more effect on the bladder because of the autonomic neuropathy, and the polyuria will become more established, and it will have more load for the bladder, and the patient will have other problems, and you don't really need to do anything else, just doing the intermittent catheterization.
But sir, we have ruled out the diabetes insipidus in this patient. There was no component of polyuria in this
Well, I
patient.
mean, I know
Yeah, the
that, but
total
most
output
of the
was 1.1 liter only. Yeah,
yeah, but
24 hours.
in the follow-up, I mean, if you can see the patient later, the diabetes insipidus will become visible again.
Okay.
We reported 14 patients. If you look at the literature, it's still one of the largest series from a single center. They all show progression in all those findings, like the optical atrophy, diabetes insipidus, mellitus. It's a progressive disease, and after all the components have progressed enough, you end up with a large atonic bladder, bilateral upper tract changes.
So, what will be the time frame, sir? After how long it will change from the detrusor overactivity from
I cannot really tell you about the time frame.
approximately?
But, yeah, I think it's still maybe 5-10 years. But
5 to 10.
Before the Didmos syndrome was named as a problem for bladder,
Yes.
it was believed that it always presents itself with large atonic bladders, because nobody looked at the bladders with Didmos syndrome. They only realized that they present with large atonic bladders. After it's been defined as creating a bladder problem, then people started looking at it, and we did. I think it was in 2000. We published, it was the largest series then. And actually, we were able to look at some earlier patients because nobody looked at those earlier patients.
Yes.
And we've seen the overactivity of bladder. And if you can find that publication, we said that they also present themselves with overactivity. And your case is another sample of it. But in the long run, they will all end up with large atonic bladders.
Yes, maybe it is the earlier presentation of
Yes,
from
I think
syndrome.
so.
Yeah,
Yeah.
definitely.
Your
Yes,
point
I think
well
that's
taken. Yes, sir.
Yes.
Your
Yeah.
point well taken, sir. Age in this case, the age of presentation is very early. Generally, in
Yeah.
Wolfram syndrome, the age of urological involvement is at the age of 20. Median age is 20, as literature
Yeah.
says, sir. But in this case, sir, elder brother is also having similar history. So the family concerned about the problem, and they presented early to the hospital.
Yeah.
In
Yeah.
later stage, it may present with atonic bladder, sir.
True.
Yeah. We have
So
to.
I want to ask with the Takwani sir. Hello, sir. Anil Takwani, sir.
Anil Takwan is probably driving here. Oh, he's
Yeah,
there.
hello.
Okay. Yes, sir. Yes, sir.
Yes.
I want to question, sir. Is
I
there
may
any
not
role of
be
your voice is breaking?
he's right, Massimo is right. I'm
It's okay, sir. It's
what
okay.
if
It's
the
okay.
other question wishes
Okay,
to
okay.
other, yeah.
Yes, sir. So Tegul, sir, one more question. So we have not done the video
Tegul
urinary.
sir has left. So Tegul and Malika Arjun left
No,
already.
No, I'm
I am
here.
listening, you people.
Yeah, no, sir is here. Sir is here online. Yes, sir. Sir is actively
Okay.
participating here. So Tegul sir, I want to one question that what is the if we would have done MCU or video urodynamic, so will be any change in the pathway of the management, because we have not done the this one VCUG nor the video urodynamic, but we
Well,
followed with the yes.
if the presence of reflux may have an impact on your management. If the
What
patient is not having febrile urinary tract infection, it's good. But if the patient is having febrile urinary tract infections, maybe you may consider doing an injection therapy or something to stop that reflux at least. Because most of
Before
those
sir,
UVJs,
before treatment of detrusor overactivity.
no. If
Yeah.
it becomes symptomatic,
Okay.
either you can do the VCG earlier and know that there's reflux, or you can do it after the febrile urinary tract infection. But it's important to know if there's reflux.
Yes, yes.
And also about the antibiotic prophylaxis, we'll see the
also.
same. If you do not have a reflux, perhaps you can spare the prophylaxis.
Yeah, also.
Yes.
Yeah.
Okay, thank you so much, sir. This is
Dr.
Ansari, sir.
Chua? Yes,
Yeah.
Dr. Chua, do you want to make any comment about this? More from your experience?
Yeah, Unfortunately, they never encountered such a syndrome, but one thing that indeed I would involve our nephrology and endocrinology colleagues into this case management. It's a multidisciplinary team probably needs to be involved in such a case of complexity. That's the only advice I would have if I encounter a similar case.
I fully agree with you. Basically, this child was routed from the pediatric endocrinologist to us.
Yeah, it's a pediatric endocrinology case anyhow. I mean,
Yes.
they're the first one to see it.
So, can we continue or feeling tired now? We can have quickly the third case.
I have to go.
Okay. And Dr. Massimo, and so before you leave, Dr. Chua, can you share your slide? So
Oh,
just a moment.
yeah, thanks. Thank you for allowing me. I'll just send to the group chat. It's actually announcing the ICCS annual meeting next year will be in Toronto, as well as the PUV working group, which Massimo is involved for. PUV working group will be in Toronto as well. So next year, November 4 to 7. That's the only thing that I just need to announce before Dr. Tegul run to their dinner. So I'll just put the poster onto the chat group so everyone have an awareness. And the registration will be open in January, and we welcome everyone to join us in Toronto next year.
Okay.
Very good.
Thank you. Thank you.
I found our paper, which was published in 1999 in the Journal of Urology, and I pasted the conclusion from that paper into the chat box. There were 14 cases we looked at, and this was the first time that we said that it could be this synergia may be involved in the high pressure bladder as well, in the Wolfram syndrome.
Okay. Thank you, sir. We'll go through it. Okay. Thank you so much.
I pasted in this chat box. Okay.
Yeah.
Thank you.
Dr. Ansari, this was a great meeting. And it was a very good review of the neurogenic bladder, and happy to have our colleagues bringing different opinions, different approaches. It was teaching for all of us. Thank you.
Thank you very much to have you. It is always a great pleasure to have you. And you're so interactive and informative on most of the pediatricological disorders. Thank you very much, sir, for taking time from your busy schedule in India. Thank you very much.
Bye-bye. Thank you. I have to go. Bye-bye.
Bye. So, Dr. Chua and Dr. Massimo, can we have quickly third round just within 10 minutes? If we are, if both of you.
10 minutes. 10 minutes. No more than 10 minutes, because I
Oh,
also
okay,
have...
5-10 minutes quickly. Dr. Nitika, are you there?
Yes, sir.
Please share. Just a minute. Oh, let me share from here. Just wait.
Hello.
Dr. Takwani?
Yes, sir. Can I take your leave? Because I'm listening, but I'm not able to participate because of some voice issues, right?
Correct. Please go ahead.
Yeah, thank you. I enjoyed the meeting. Thank you very much, Massimo. Thank you very much, Dr. Chua, for participating. Thank you very much, all residents, those who have participated. And Ansari, sir, you have done fantastic. Thank you very much.
Thank you so much, sir. Thank you, Dr. Anil. Have a delicious dinner now.
Thank you, sir. Thank you.
So, slides are visible?
Yes, sir.
Yes. So, coming to the third case quickly, this is the story of the 10-year-old female with a history of hesitancy, poor urinary stream, intermittency, as well as straining and sense of incomplete voiding for last 4 years, sorry. And he also had back pain since 3 years, which was mild, intermittent, not relating to lower limb. And there was no history of lower limb weakness or any paresthesia. And this was gradual in onset and progressed slowly over the years. So she also had bowel symptoms with Bristol type 3 and passing 2 to 3 per week. And there was no fecal incontinence. As such, there was no storage LURS, incontinence, dysuria, turbiduria, fever or trauma. And the past history, she had history of retention 3 years back. she was catheterized for 1 day. And the physician gave alpha blocker, and she had partial improvement. But she was unable to void without medications, and family history is nothing much significant. On examination, most of the parameters were normal. So on local clinical examination and focal neurological examination was more or less normal, and the back and spine showed mild pain uh, uh, on palpation in the midline at L4, L5 level, and the pain worsened on flexion or extension. So it is leaning forward or hyperextensions. So what is your differential diagnosis now?
Sir, keeping in yes, sir. So keeping in mind age of the patient and the symptoms, I would like to keep dysfunctional voiding as one of the differentials. Neurogenic bladder due to radiopathy or any occult spinal diaphragm. However, even though we did not have any stigmata of the occult diaphragm, but lower down the order, I'll keep the spinal diaphragm as one of the differentials.
So, Dr. Chua, Dr. Massimo, any other thought regarding so far clinical presentation, 11-year-old with lower back pain with both obstructive as well as irritative symptoms?
Well, you can count in the differential diagnosis Fowler syndrome if you.
Yes, Fowler syndrome. Yes. But I think that is the another name for dysfunctional voiding in females.
Well, can be argued with that.
Okay. Yes. So, what workup do you suggest in this child?
So I would like to have the status, know the status of the urinary tract, sir. So for that, I would like to have serum creatinine in routine examination, see for any albuminuria or urea, and also to see for any bacteria. And followed by, I would like to have bladder diary in this patient as well to see her voided volumes and frequency.
So this is the bladder diary. This is quite congested. I give you the summary. Yes.
Okay. So her mean voided volume is around 200 ml, and the maximum voided volume was 250. Her frequency in the daytime is 3 to 4, which is not. And she has the episode of urea as well. There is urgent no leak in this case.
Okay, giving you the ultrasonography because we are already going slow. So this was the ultrasonograph. Yes.
So in this ultrasound, I can appreciate that right and the left kidney do not have any dilatation of the pelvic ileal system, and the cortical is normal, and the cortical thickness is normal. In the bladder cuts, I can see the bladder is distended, and bladder is. PVR in this patient, as given its height is 315 ml.
So obviously you will need uroflowmetry. This is the uroflowmetry and these are the parameters. Yes.
Yes, sir. This is typical radiant voiding pattern with the curves touching the baseline as well. So for one urology in this patient as well, like because I have keeping my dysfunctional voiding as one of the differentials. So
Okay.
as I can see, sir, in the flow EMG, there is sphincter overactivity in the voiding phase, and the flow appears to be very poor. The average flow is about 3.3 and the PVR is remaining at 192 ml.
So any other investigation you will like to have?
Yeah, before rule out urogenic bladder from dysfunctional voiding, I would like to have MRI in this patient as well, since she had history of pain since last 3 years, which was progressive.
But focused neurological examination was normal. And in spite of that, you're suspecting neurogenic bladder.
Yes, sir. Since there is EMG overactivity, you cannot definitely rule out involvement.
Okay. So this is the MRI.
So the MRI findings reveal that there is a lumbar canal stenosis and there is mild anterolysis at L4, L5. I can appreciate that in the picture, and nerve roots.
So what is your now working diagnosis for this?
So now I need to make my diagnosis as neurogenic urinary tract dysfunction, secondary to canal stenosis due to degenerative disc disease.
So okay, obviously now you will be needing this video, this urodynamics. Please read this.
There is the filling. If I come to the filling phase first, I can appreciate there is some detrusor overactivity. However, there is no release in the flow in that time. So there is detrusor overactivity without leak. And if I come to the voiding phase, the detrusor pressures seem to be high, and however, flow is still intermittent and poor. And I can appreciate that the EMG is overactive in this case. So I would likely label it as detrusor sphincter dyssynergia with DO.
So before we discuss, I give you the final diagnosis here. So these are the parameters.
Yes, sir, the compliance is normal in this case. The end filling pressures are about 12, so they're well below 15. However, the reading phase, I can see that the PVR is high and the maximum flow rate is 11.9, while the pressures at maximum flow is 60 and the maximum detrusor pressure is 77.
So final diagnosis, I give you this.
Yes, sir. So it's neurogenic lower urinary tract dysfunction secondary to spinal canal stenosis with detrusor external sphincter dysfunction and detrusor overactivity.
So
with high PVR as well.
So risk stratification we have already discussed. This was a low risk, and just to pass quickly, and how to manage this patient now.
So again, sir, as previously discussed by Dr. Alok and Dr. Gaji, I'll start this patient first, since she had a definitive finding in the MRI spine. So neurological condition or neurosurgical consultation if they want to intervene this patient. Secondly, for the urinary tract symptoms, I'd like to start this patient on CIC with anticholinergics and alpha blockers. And still, since the patient also has appreciable bowel symptoms, I'll like keep her on bowel according to our institution protocol. And so
these are the algorithm chart. Now it is available, and treatment started was CIC, anticholinergic, and alpha blocker, bowel management, pelvic floor exercise, and the biofeedback. And yes, and response assessment was done on the basis of bladder diary, ultrasonography, and the renal function test. So this was this EMG uroflowmetry before, and this was after. Comment.
yes, sir. Before the urotherapy, there is considerable EMG overactivity. Flow is poor. PVR is also high. After 3 months of treatment, there is some reduction in the EMG overactivity. However, still there is appreciable EMG overactivity and the PVR is still high. And
Dr. Chua, yes, please. Now we have reached to the point. Yes.
Yeah, sorry. The only thing is I noticed that the neurosurgery kind of managed this very conservatively, but on our part though, we probably will refer this to physiotherapy or really address the prolapsing or protruding disc. Maybe the patient is actually carrying heavy weight every day, or those things that might need to avoid a little bit. I know she's not overweight, but I think we need to address the main cause of this whole symptom. So she might need to be referred for some stretching exercise or Pilates even to kind of stretch out the area that's protruding to causing canal stenosis. So that's the only advice I would have in this space. Rather than just focusing on the muscle on our EMG, we also need to go back to what's causing these symptoms.
Correct. But as a whole, she needs a pelvic floor rehabilitation and proper exercise sessions just to get relief. So this is before and after. Dr. Massimo.
I can see definitely a good improvement, although it's not much of a, it's not a full resolution yet. So yeah, I think that this is definitely demonstrating some improvement.
So there is some improvement, but the intensity of sphincter is not that severe, but still she is not relieved fully.
Yeah, I mean, I guess that CSC has been counted as well as
Yes.
as an intervention.
In spite of rigorous pelvic floor biofeedback exercises also, she learned it. She's doing at home, but still the detrusor sphincter activity is persisting. Not to the same magnitude previously, but it is still there. So the second line is, Dr. Nandika, what will you do now? But the family is not very much satisfied.
So since her symptoms are mildly relieved and on urology we can appreciate sphincter activity and PVR is still, I would like to consider Botox, intrasphincteric Botox in this patient.
Your thoughts, Dr. Chua and Dr. Massimo? Yes.
Why urethral dilatation?
Because this has been mentioned in the many of the guidelines and literature also. So that is why we have put it here to know.
Yeah, I don't find that.
Yeah, so I think it's more on in adult literature that they may consider, particularly for those elderly women. But in pediatrics, though, I don't also see the need for urethral dilatation. But in transpheric Botox, it's kind of part of our pathway here that we do quite a lot already.
Thank you. Dr. Massimo, Botox,
Yeah.
you will agree with if she is not responding with multiple sessions of biofeedback, even pelvic floor relaxation, she is practicing at home. And if she's not getting full relief, then Botox may be an option for this.
It may be an option, not the one that I would go easily, but I can see an option for that.
Okay. So with this, we can conclude this session. So, thank you very much, Dr. Massimo and Dr. Chua, for holding both of you for such a long time. Thank you very much.
Thank you very much. I would agree with what Serdar said before. It was an amazing session. It was very thorough, and I learned a lot. Thank you for that. Thank you for having me.
So next time we will be having Dr. Chua, and next time make Dr. Skinder to be readily available for us also. And India is eagerly waiting for him.
Oh, well, if you invite us, we'll be looking forward to come again. It's amazing.
And we're looking forward for everyone to ICCS and PUV working group next year as well in Toronto.
For surely, Dr. Chua will be there at SickKid. Yes.
Yeah.
Next
Thank you.
time. Okay. And Dr. Massimo is already working very hard for the society for on PUV.
Thank you very much.
And so thank you both of you, Dr. Massimo and Dr. Chua and Dr. Tegul also, and all the panelists, Dr. Takwani, Dr. Malika also, for this wonderful session. I also thank Dr. Anupam, Dr. Alok, Dr. Gajendra, and Dr. Nitika. And Aryan is left. Hannah, but do not feel, Aryan, in the next presentation, even if you are a consultant, then we will rope you in. Thank you very much, all of you.
Thank you so much, sir.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you.